Okay, so good morning. Good morning. Hopefully we're missing some people, they'll come. So today Kate needed some rest. So she's just taking some rest today. So unfortunately you only have me. So hopefully I can keep things interesting for you. So because Kate is not here, I will try to do some of her parts as best as possible. And she and I discussed, and there's some few extra things that we would like to give, some more examples, and some more details about certain concepts that we want to build on. So the schedule will switch around a little bit, but hopefully everything makes sense. Ready? Okay, so let's start here. So what I'm going to do is just finish 6.2, but I'm going to skip there's a few slides previously that were about odds ratio and relative risk and so on. I'm going to do that in a little more detail in a different PowerPoint. So let me just do the kind of conceptual, the kind of considerations part first. And then we will go into a little bit more of the statistic, and then that'll be the morning until the break. I think we'll spend some time on that, and then we will go to the next topic from there. So we have been together for now 6 days of talking about research methods. Just to pause before we get started, like just any questions or thoughts or things that you're finding easy or confusing. How are you feeling? How's the material? It's okay? So let's talk about, so we are in the middle of a very detailed look at epidemiological study designs, right? And we had talked, Kate had spoken about kind of cross-sectional prevalence surveillance, this design. Can you remind me, what is this kind of design? What is it exactly? What is like a cross-sectional study or design? What does it look like?
It's a thing about speaking and analytics.
Right.
The causes not including analytics. Causes for normal we have is and we know about the important is high quality, but high budget like that. And sometimes we didn't have time, we didn't have money, and we choose one.
Yeah, that is a nice big picture summary. But cross-sectional study itself, what does it look like? If I tell you I'm going to go do a cross-sectional study on breastfeeding, what do you understand from that?
We understand about relationship, associate, and know about its appearance, but we didn't know its cause and effect. Which one is caused by. If we use the breastfeeding outcome, the nutritional status outcome and exposure is the breastfeeding, yes or no. And then we saw about relationship, but we didn't say that it's called the first happen is nutritional status or breastfeeding first.
Yeah, so that's a nice example. So like for others, like, so why can't you tell? Like there's one critical part of a cross sectional design that makes it difficult, is where you can't tell cause and effect. Like, why is that? Do you know the answer? Yeah, good.
But each project is 1 point of the time.
Yes, yeah.
So this cross-sectional.
Right, yeah. So cross-sectional means it's one section of time, not all, like multiple time. So what happens is that, so many studies, I think if you have done studies or if your students have done studies, many of them are cross-sectional. right? They go to a community, they do a survey, or they do anthropometry, or they do dietary assessment. They go, maybe they take 1 month, 2 months, but all at once, just one together, and they don't go back again. They do the job, they get the data, they come back and they analyze. They might do, like some of you might do some research that way, or your students, maybe if they have a project or they have a thesis or something like that. That's a very common thing because especially for students, they don't have time. You can't do like a 1-year study, if you're a master's student. So you go, you collect your data, you analyze, you demonstrate, you understand some knowledge, and then you get your master's degree and you go. So that's probably very familiar for you. But the problem is the temporality. So that's a really good question. So for example, I just to make sure that it's very, very clear. Like say that I go to a population, maybe it's in the capital city, and I estimate, so here's my whole city, and then I'm randomly sampling adults in this, and I measure BMI, for example, and I find out the BMI, okay, maybe it's a US city, let's say that, some city, and maybe the BMI is 30. So that is kind of like overweight going to obese, right? So pretty high BMI. And let's say I do dietary assessment and I find out people are eating 3,000 calories per day, 3 calories per day. So they're eating a lot and they have a high BMI. Now, probably you hypothesize, okay, they're having too much energy and therefore they gain weight. And therefore, so the diet is causing this increase in body mass, right? That's a reasonable hypothesis, but you can't prove that. And actually, it's very possible people who have more body mass, our energy requirements are based on our body mass. So people who are bigger need to eat more because the requirement for energy is per kilogram of body mass. So it might be, so it's very logical to say you eat high energy diet, you have high BMI, but also people with high BMI will naturally, even to maintain that BMI, would eat a high energy diet. So it's possible the error goes this way, can also go a little bit the other way. So that's why, is this causing that or is this causing that? Because I have more body mass, I eat more to maintain myself. That's very possible, right? So that is why we have this problem of causality. Same thing, if this was a very small number and you look at child stunting, right? Stunting is, so that's another good one. Let's say that you have, let's say you do, in children, percent of inadequate energy. You do a dietary assessment of children and you find out maybe, 30% are not eating enough. They don't get enough energy, so there's food insecurity maybe. And then maybe you get 40% stunting, a lot. Now, it's also reasonable to say, okay, the children are not eating well, and it explains the chronic malnutrition. But the problem is, when you do this kind of work, usually you do something like a 24-hour recall, right? You ask, what did you eat yesterday? What did this baby eat yesterday, right? This is one day, usually. Maybe it's 1 week. Maybe you do FMQ, maybe you do a weight record. Kerman had showed different kind of methods to use, but usually this is a very recent recall, right? You don't ask what did the baby eat in January, like nobody remembers. So usually it's yesterday. Stunting takes months to happen, right? If you don't eat well yesterday, you don't become stunted today. You have to keep eating poorly, and 6 months later, you might see stunting, right? So these 40% of children who have stunting, it's because of an exposure that didn't happen yesterday. It might have happened in January. right? And February, it had to be for a longer time, right? And in fact, you might find that, this is actually zero, like the children are eating very well and they have stunting, but it's because maybe now there's good food. Maybe 6 months ago, there was food insecurity. Maybe the food price was too high and that created some stunting. Maybe 6 months ago, there was a lot of disease, the children were sick very often, and that led to stunting. But right now, the diet is fine. That doesn't mean diet is not important. Diet is still important, but it just right now you can't establish this connection because of the time required. Make sense?
But we can answer to reasonable for study when we already the 24 hours and answer this study is still through the diet. In 24 hours, we collect the data and after study is anyway.
Sorry, to do 24-hour recall and then connect to something?
Yeah, something we compare the image like we ask them 24 before. Then we ask the result is significant study related to the energy or the
Right. There's a big assumption. And the big assumption you're making is that the diet of yesterday is like the diet of previous time, right? That's really what you're assuming. You're saying that, okay, if I try to make some connection between diet and anthropometry, for example, or nutritional status, that this diet of yesterday is somehow representative of previous times. And you have to know your context very well. Certainly for the places where I do research, and in many countries, like the diet is seasonal, right? Like there are times where, for example, when there's harvest time, there's a lot of food. In times before the harvest, things are tough. There are times where food prices are very high. So often we don't have that luxury, So you have to make that big assumption, but people will give you a hard time for that kind of assumption. Okay, so that is what, and this is like a long explanation for, let me just duplicate for myself so I can see better. So if I do this, can you see? Yeah, kind of. This first bullet, that's what we're talking about. Temporality is just about the time. So you don't know what is causing what. This idea of survival bias is, for example, like here's my population. Suppose I go today and I'm just trying to understand what is the rate of cervical cancer, right? And I counted my population and I survey, 10,000, I screen 10,000 and I find some rate of cervical cancer. Right? Obviously, those are the people I screen are the ones who are surviving. So the person who died last week from cervical cancer is missing from my data, right? So that it is giving you a natural kind of bias that the people, if there is an outcome that is going to lead to mortality and you look at only one time point, you may not get a very clear picture because new cases are coming and then you have mortality. And so it's continuously changing like that. So the bias of this survival bias means that those who are surviving are the ones who get counted. The ones who die, they're missing from your data, and it will change the numbers a little bit. So that's that idea. Another thing is about consenting. So this last one, they called it healthy worker because that's the idea of maybe if you do this study in an office or a working place, right? But you can do this even in a community. This idea is who you actually select. So perhaps you go to a village, you get the list of all the children and you randomly pick, but you have to get consent, right? You always have to have people to agree to participate. Otherwise you can't proceed. But who are the people who don't consent? That's something you should think about a lot.
Yes.
Yeah, sorry?
Legacy.
Yeah, exactly. So and I think I used that example before last week. I think we were talking about estimating stunting. if you're trying to look at stunting, and there's maybe the true prevalence is, 40%, it's very high, stunting. But when you ask people to come and get measurements, to participate in your study, like some of these ones were children who are stunted, maybe they're sick, right? So they're not healthy, the mothers will not bring, because it's too much for a sick child. Some of these stunted might be very poor, they cannot afford to take a bus, and they cannot come to get measurement. Or some of them live very far in some kind of marginal area, so again, it's difficult for them. So you're missing those people as well. You're going to, in all likelihood, get more healthy participants. The ones who are healthy, the ones who, have more resources, more money, more support, things like that are probably more likely to participate in any kind of study, because the ones who have a disadvantage, it's difficult for them. So that will create some kind of bias as well. You miss people that you're very interested in. So your numbers will change. And you have to kind of just be aware, and you don't know how your numbers are changing, right? Maybe when you actually measure, maybe when you actually measure, you only find 35% stunting, when the truth is 40, or maybe the difference is even bigger. You don't know the difference between what you measure and what is the truth, because we don't know the difference. So the best we can do is kind of understand what type of bias might be happening and just be aware, right? If I go to the study and I calculate 35% stunting, and I know that there might be some bias, maybe then I would know this is maybe the best case scenario. Maybe the truth is worse, right? And then you can plan accordingly. So those are kind of some sources of bias. Makes sense, these considerations? Okay. So these kinds of studies are very nice. They can be done very fast. Sometimes even if they're sensitive, you don't even need to necessarily keep very close track of the people who are participating, because you collect data one time, you're not going back again. You don't need to follow them. So you don't need to keep a detailed record of contact information and so on. So it's certainly cheaper and so on. It lets you answer some questions, but there's some limitations, right? There's limitations in terms of causality, for sure. But it still can be quite useful. I actually wanted to talk about this a little bit, because I don't know as much about Lao, so you can tell me. But I had a colleague who did a similar kind of work in West Africa. And she did a very thorough review of the research in different countries of West Africa and kind of looked at study designs. So this is a very common study design, and it's usually kind of helps you understand a problem. Like, how much stunting is there in this population? You get an idea. What is the breastfeeding rates? You understand what the problems are. It doesn't give, because we can't look at cause and effect, we don't really have an idea of solutions. We don't really have an idea of reasons. We get we get a little bit of idea, right? If we look at stunting and then we look at breastfeeding or socioeconomic status, we can understand some associations and develop some hypotheses, but the evidence is limited, right? And really what we're doing is really finding problems. And that is important, but it's never going to the next level of trying to find solutions, right? So I think one of the things when we think about, and certainly when I am working in the African context, and you're trying to elevate the research and the quality of the research that is happening in a country, this is good, but it's good to kind of think about other study designs that are maybe more rigorous. Things that are longitudinal, like a cohort study, like RCTs, that can build stronger evidence, right? This is very descriptive, this work, and it will tell you what the problems are. It really doesn't help with solutions. So if you're thinking in a very big picture for your institution, for your personal, research plan for your career and also for your institution about how you want to build research in your institution. Think about, doing more, the stronger evidence study designs, things like a cohort study, things like RCTs, because those things really have a lot of power, to answer questions. I don't mean statistical power, but there's a lot of value there, and it does elevate your research and what you can do. The problem with those kinds of studies is that they are more difficult. They take more resources. They can be challenging in a lot of ways, right? Like just the mechanics. If you have ever done this kind of study, you go to a community and you find babies. Babies can be somehow so difficult. You find babies, you collect data, and you try to go next year and find the same babies. That can be hard, right? Like everybody has a name, but then they have a nickname, right? And now suddenly this baby also has a brother or sister. Like which child was it? Even in one house, like, wait, is it this one or is it that one? If you don't have good records, sometimes it's very difficult to get the same person again and again. Same thing if you have HIV patient, right? And you want to measure them over time. Sometimes they don't come to the clinic. They miss a visit. Sometimes they die, right? Like sometimes they move away to somewhere. Sometimes they, have a problem in the family or even any family. Like sometimes you have the husband and wife separate and one goes here and one goes back to the village or, like many things happen when you work longitudinally and it makes your life very complicated. So that can be hard, this longitudinal studies. I once did actually it was that example of malaria and pregnancy. We, here we're following pregnancy, we have to follow the same woman and we give every woman an ID number and we keep track very carefully. And one thing we did very badly was once the baby is born, we have to collect data on mother and child. For example, you might take blood, right? From mother and from baby, and you measure hemoglobin and whatever, something like that. So you have one ID number for one woman. After delivery, you have two people. So now how do you separate the blood sample of mother and baby? Like you collect them at the same time, but you have to now you need two ID numbers. Like maybe you put -1 and -2 or -mother, -baby, something like that. Like just kind of keeping track of that. We realized we were getting confused on our samples because we didn't have a good system. It felt like a stupid mistake, but it was a mess we had to fix somehow. And some things you can't do it again, right? When you take venous blood, if you mess up the sample, it's gone, right? You can't, if you do serum, okay, fine. You can, put it in the fridge and take it out, analyze again, no problem. But for whole blood, no, right? You lose it. So these kinds of things are hard. But yeah, so always think about, and I think Dr. Kate will always emphasize this, think of when you have an experience, think about things you can do to improve the rigor. Because it has value both for the research itself, but also for you, for your institution, for the work that you're doing. It also improves the work you're doing. Okay. Okay, let me just show you some very quick examples that were in the slides. I won't spend so much time on it, of these kinds of studies. So some of these studies are one time. They just go collect data. A lot of the good ones that exist in the world are cross-sectional, but they're repeated. And a good example is the MIX study, which I think you guys have seen. We've been doing some examples for it. We have Dr. Rathapun is kind of the expert and can tell you more about it more than me. So MIX, it is cross-sectional in the sense that you go, in 2017, you went to certain families. When you go again, it'll be new families, it will be new babies. It's not like you're doing longitudinally, and find the same family again and find the same baby again, and now it's big. No, you resample and then get a new collection of people so you can make some comparisons, but it is cross-sectional at each time.
What's the difference between this study and the panel study?
Panel study will have the same, it's like, panel study is like longitudinal, it's like a cohort. Panel study, the economists like to use that word panel, whereas epidemiologists like to use the word cohort.
Oh.
But it's,
But panel study, we are not following the same subject, right? A different subject, but in the same group, but different subject.
the usual way of panels, okay, people do things in many different ways. So sometimes people will mix a panel study. Like, I would not call mix a panel study. A panel study is usually less frequent. It's like a cohort, less frequent, but it's longitudinal. Like, you keep the same people. Sometimes there's certain panel studies where, you know, as you follow people over time, you lose people. Like, they naturally drop out, they move away, they migrate, they die, many things can happen. There are some panel studies that every round, they will refresh new people. So they're monitoring some people the same, like, over time, but then they realize, okay, I have attrition, I'm losing people, so this round, I will increase my sample by 10%. So it's a new random sample, and then next time I get another 10%. And like that, and so they kind of refresh that way.
Mirroring result of each during time.
Yeah, so I mean, the idea there is sometimes, so if you do that 10% 10 times, then you end up with a totally new sample.
Is it good for long-term follow-up of the intervention?
Yes, yeah, for long-term follow-up, you need the same people, right? You need to watch them. Like the example we did yesterday, where they did an RCT during like preconceptional anemia, and then they just followed the same mothers and babies for 6, 7, 8 years.
Yeah, please correct me if I'm wrong. Because I thought that a lot of nutritional literacy interventions in school or in community somewhere, people or the research team try to measure pre and post. Okay, either randomized or quasi control, whatever. And they try to reassess. In the meantime, that they can see the significant change of the score of something that they want to measure on one time. But maybe after that, they might forget everything that you have intervened already.
Right.
Like that.
Yeah. You might just have 2 time points with an intervention in the middle.
But I think it's not that fair, because you just want to see studies about significance. Not really want to see long-term effect of your intervention.
Yeah, that is a whole different. A long-term effect is a whole different thing. And there are some studies that are like really good. The one that we discussed yesterday on the preconceptional anemia, like that, you know, that are really quite rigorous. And as they go over time, they don't lose. If you lose 50% of your people, then you can create bias, right? But if you can really keep track of people over time, beyond your intervention, you can look at long-term effects. And there are very few studies like that. They are very nice studies. It's because you need a lot of resource to keep this. You have to stay in contact. You know, that assessed cognitive function in children 6 to 7 years, right? And the enrollment was before conception, right? So imagine that there's one PI who is like, you know, and one kind of leadership team and funding for what, 10 years? Like, very rare, right? But if you do keep good records, one good strategy is like if you have an RCT, you have good records, you have a good connection to the people, a good relationship, then if you get a different kind of funding, you can do follow-up studies. This is really good in things like kind of like looking at long-term effects. A lot of this work on like child development, like early life exposures on child development. That's a nice study design. Yeah.
So the Tanyan study is the same with the longitudinal studies.
Yeah, but there are many
more. If you would like to look at the weight gain, low pregnancy, and the result with the baby or the same.
So that kind of thing you would want so this word panel, people use it in different ways, and there are so many variations, right? So panel, some of them are purely a cohort. Some of them are refreshing, a small amount, like I was describing, 10% in each round. Some of them are like mixed. It's a total like new sample every time. And they still kind of use that word. So you really have to like know the method, and the way you analyze it's going to be completely different, right? If it's the same people over time, then my measurements over time are correlated, right? They're not independent, they're related somehow. So in your analysis, you need to take that into account. If you measure a new group each time, it's sort of like independent sample, right? It's the same idea, like if you remember, like when we talked about independent sample t-test and paired t-test, it's a totally different analysis because one of them is like totally separate, independent, and one is like completely connected. And you have to analyze it. So yeah, so when you hear those kinds of words, it's always good to just kind of check the methods of how people do it. And the other problem is that there's a lot of disciplinary difference. So if you ask Professor Shifley, like Jerry, he would say, he probably uses the word panel more. If you ask Dr. Kate, like she will use the word cohort, right? Because she's an epidemiologist, he is an economist, and they have different words. Sometimes for the same thing, sometimes for slightly different thing. Like, so that is difficult sometimes to do that. For me, I would just say longitudinal study. Like, I really don't care if it's cohort or entity, because the issue is the time, the repeated measuring of the same people. So, everybody has these different words, like even in one language, it's different words, it gets confusing. So you really have to check the methods. Yeah, so mix, there's an example from WFP here. This one in Haynes, you see a lot. There are certain studies, especially in Europe, in some places in Asia, but a lot in the US, that are kind of these very big studies, very big data sets that help you look at relationships between exposures and outcomes. In Haynes, it just stands for something national, I don't know, health and nutrition, something survey. Oh, here, it's there, nutrition examination survey, it's there, and Haynes. Like, if you read papers that are epidemiological, especially around like things like diet or child feeding or physical activity, you'll see that one a lot. It's just a public data set that's available, and people just do lots of analysis, and many people work on these kinds of things. These kinds of very big studies that are public data sets are a nice opportunity sometimes if you just want to do research, because the data, it's there, it's clean. You don't have to enter any data, you don't have to clean anything, it's ready to go. You can answer things, but obviously, like, for example, this data set is American, right? So whatever you study, the results are for an American population. Is it going to generalize to Asia or Africa? Who knows? Probably not, maybe. But still, it is a good, kind of strategy to use some of these big existing data sets. And nowadays, there are more and more of data sets like this. And things like this are also useful to study, because if you're interested in doing something like this, say in Lao, they have developed all sorts of good methodology because they have been doing it for many years. They know how to manage data. They have questionnaires. They have a whole system of cleaning the data, collecting the data, quality control. So when you see those kinds of systems as well, you can just learn like kind of good practice that has been used a lot, and people know that it's working very well. And you can think about how you can use those practices. So sometimes kind of finding one of these big studies in the world and just looking at their operational, like how their operation structure and their methods and, how they do quality control, things like that can help improve your own work of seeing good examples. So actually, like, there's a link here about the operations, so you can check that kind of thing. Okay, so when you do these kinds of more cross-sectional type studies, there are maybe 500 questions, and you can see several of these kinds of questions here, thinking about how you recruit people, how you get the sample, what do you measure, and then how do you analyze. So thinking about how you sample, recruitment, Do you give compensation for people for participation? Do you give them a gift? Do you give them money? Things like that. Who is doing the recruitment, sample size? There's a lot here. Like we can spend maybe one whole day like talking, or even one whole week talking about these kinds of things. Because all of these different little decisions can affect who is participating, right? Like if you have data collectors who all use one language and the population is using a mixture of language, then you will only get the people who kind of speak the same language. You maybe don't get the others. You know, so there's all sorts of things that you can choose in your day-to-day operations that will create bias. And that's the one thing to kind of think about. So how do you make things representative? Training, adherence to protocols. I think from my experience, and you can tell me your experience also, like sometimes you have a project, you get a budget is kind of tight. And then you calculate, okay, I need 30 days for data collection with 10 data collectors and something like this. And then you're like, wait, I need to do training. And then it's like, okay, but the budget is the same and I need to collect the data. Maybe I can do 2 days of training, but maybe it becomes 1 day of training because I just don't have the resource to keep people in a training room talking all day, right? Like, so you cut the training, which is oftentimes a big mistake, right? Because then your data collectors may not understand very well and your data becomes very different from person to person. There has been a lot of good research, and I think Dr. Kate can give a good example because she was talking about one study she did where she found some differences in outcomes and they're studying it. And they found out the biggest predictor of differences in the outcome in the sample was the interviewer. Certain interviewers had certain kinds of measurements and the other ones had other kinds of measurements. And that can happen for everything. It can happen for anthropometry because some people are very careful and measure very correctly and others are, not as careful. Or they might overestimate or underestimate or just be too noisy because they're not well trained or they're just not, they need more supervision. But even in certain kinds of questions, because a lot of things we ask are a little bit subjective or they're very sensitive. Like maybe we ask you about your food insecurity. Maybe we ask you about mental health, right? And people don't want to tell you everything, right? So the way that somebody is trained of how to ask those questions is very, very important. If they're not, kind of gentle or they don't build trust, people are not going to tell them. So you might find that, you collect data with Kate and you find out a certain rate of mental health problems. Everybody is sharing their problems and you find that 20% of the population or the sample with Kate, 20% will tell that they have a problem. And with me, they're not comfortable. And so you only find 10%, like that will happen. And sometimes I do, when I'm checking my data, I just check outcomes by interviewer. So whenever you're collecting data, make sure you collect some variable that says who collected this data and just check to see if there's any differences, right? If you look at the height for age or, height of baby across interviewers, it should be random who gets which interviewer, right? Should be about the same. And if there's any difference where, this one always has a big baby or a small baby, you need to go to that person and maybe retrain or something like that. Yeah.
I used to assess the knowledge score of samples between different data collectors. Mm-hmm. And I used to find the significance difference between different data collectors.
Yeah.
In the pilot study.
Mm-hmm. It is really good to check that and to do things like pre-test, post-test for trainings, to make sure that they have the minimum knowledge and to be kind of tough about making sure that everybody needs a certain level of knowledge. It's also true for implementers. You know, like if you're working with health workers and they are delivering the intervention, you know, health workers have very different backgrounds and very different commitment to work. I don't know about that, but like in other places, you know, the background can vary, the commitment and the doing the work. It's different. Some are very serious, some are less serious, or they have other jobs, or so many things. So to make sure that there's some consistency.
I think it's the one main barrier for us is when we use the standard tool to translate from English to Lao. This is also barrier because some word is especially for the one in for the mental health or something. It's very similar in English, but when we translate in Lao, it's look the same.
It doesn't make any kind of sense. Yeah, yeah, we did, and
sometimes very
yeah, things like mental health or like something very women's empowerment, things like that. The words are very important, and even the scale can matter. So like women's empowerment has oftentimes different domains. In some culture, some domains are more important, right? Like in if you go to some, you know, Tanzania, you know, East Africa, like certain aspects of women's empowerment are the really important issues there. Here in Lao, it might be like other things, you know, like that is more important. So we did a study on mental health actually in Tanzania, and we took a tool from the US. So it has questions. Do you have the symptom? Never, sometimes, or never, rarely, sometimes, frequently, 5 times a day. I don't know. You know, there was some kind of scale like that. And in the American system, like you kind of give a score for each one and you sum the scores and you get like a number. And if the number is more than this, then it looks like they have depression and symptoms. If it's less, you know, you can make it a kind of binary, depressive symptoms or no symptoms, like that. And so there's a certain cutoff when you take like the sum of the scores. We did an entire validation study of just that tool before we ever used it. We found that the questions were okay, very carefully translated, and you had to find the right, the translate, it's not like Google Translate. Like, it's not just word for word, you have to find the right way to say it, you know, that makes sense to people. But then what we found was the cutoff was very, very different. So same questions were okay, properly translated, but like in the US, if you were, you know, if this is the scale and here is total depression, here you are very, you know, mentally okay. Like the cutoff was here for Americans, but for Tanzanians, it was here. Because Tanzanians, they don't like to say that they have a problem. Like it's not polite. If I say, how are you? And you say, oh, yeah, like they don't say that. They will always say, I am fine, I'm so fine, thank you very much. Like, so if anybody says even a little thing, it probably means that they have a serious problem, right? Like their house is burning and they say like, a little bit stressed, but you know, their house is burning, like, you know, so it meant that it had a completely different cutoff. And we did an entire study just for the validation. And then we did the true study that we wanted to do, looking at depression and ART adherence and things like that. So it is a lot of work and it's a little bit frustrating because you want to get to the actual study where you use the tool instead of spending like 5-6 months doing validation, but you might. And it will pay off because most of the times you end up with like total junk data if you don't do that. Because people don't, like the data collectors don't understand the questionnaire and the participants really don't understand the questionnaire and they will just tell you something, usually something in the middle, like, you know, like somewhat is an easy answer when you're not sure, you know, so something in the middle like that, or just yes, because
I'm not sure.
Yeah, or don't know, or, you know, so you just end up with junk data and you can't do anything anyway, so it's better to spend the time. Okay, so how you measure data, all of these things matter. And then it really helps to have the analytical plan beforehand. like really think about, okay, how am I going to analyze? Like, what is my null hypothesis? What variable do I want? How am I going to calculate? Because it will help you really think about how you set up your data system, how you create a data entry form, or you maybe collect data on tablet, how that is going to go to a spreadsheet. Like these kinds of things, if you know what you need at the end, otherwise you end up, collecting data on a tablet and you get this CSV file. It's so confusing. And then you have to clean it somehow and create some variable. And then like that part becomes very hard. So I think if you start that thought process early, you find out exactly how you want to ask the question, how you want to do data entry, it will save you a time later. I can't say that enough. That is such a headache when you get data and then you're trying to think how to analyze. Like sometimes it's too late to make a correction, right? Okay, any questions or other experience on these kinds of things? I think you guys have a lot of experience doing some of this stuff and can tell stories of what goes well and what goes badly, right? Yeah.
Partly I raised my hands so much. Regarding cross-sectional study, some cross-sectional study is already difficult, like surveillance or I don't know, and some cross-sectional study aims to analyze deeper in with a sophisticated analytical process. So and some of students and teachers in a university also confused with naming that design. What would you name it for cross-sectional study? Whether it's a descriptive cross-sectional study or analytical cross-sectional study, you may.
I would just say cross-sectional study and leave it alone. It's cross-sectional because it's one time point and people know what that is. I think in reality, like, again, like we suffer from budgets, like never having enough resources and that if you just do a descriptive study, like, I don't know why you would do that. Like, because you can describe, but then if you describe more than one thing, you can also connect them and look at how they relate. Like, you have to take the most, like for the same activity, like why not get the most you can out of it, right? So that I would imagine for a descriptive study is like, if I really just want to know something very quick, like I need to know food security in my population today, now, go and collect food security, don't bother with any of these other things, right? But if you have a student or you're doing research yourself, you're just doing description, like something's missing, you gotta do more. Like, because you're making so much effort to go to a community, enroll people, do IRB, enter data, analyze, like, why would you only do this? I just look at relationships, right? Like you looked at food insecurity, why? Why is food insecurity happening? Is it money? Is it prices? Is it, I don't know, attitudes or knowledge or something? What, like, do a little more. Yeah. Start making the most of it. Yeah. And
Yeah, I have experience to share about the positional study. So now I am looking at on the great tension of the
you have to talk louder, sorry.
Okay. So we are now collecting data in hospital related to the great tension of the diabetes and we have separate symptoms. So the one group is control diabetes only, and another group is diabetes with hypertension complication. And we found that many patients that have control diabetes is not often go to hospital because they control and the doctor appointment is maybe 3 months, 6 months to come to hospital to check up. Rather than the one that have in control, the one that have high sugar or hypertension will come every month. Yeah, so now we plan for about 1,000 sample and almost we get this just in control patient. And we waiting for the well control one. So What do you think that if we are positional that we have 50% and we need time to collect data, and for example, if we have time to collect data only 3 months, but after if the 3 months is already finished and we not completely that what do you do?
Yeah,
Or
I mean,
continue or
so in your sample, like what percent are uncontrolled?
what percent?
Yeah, what percent roughly? Is it like 80% or 90% or 50% uncontrolled?
We calculate sample size to be each group should have 180.
So you have, but like, what are the true numbers you have now? How different are they? Is it like
About 50%.
50% are uncontrolled? And
Yeah.
50% are
Yeah. For example, the in control is already complete
enrollment.
but the control one is just what they do. 20, 30,
Oh, I see.
something like that. Yeah. Because they're not often come to hospital because they're under control. So they come just only washing up.
Okay, so your situation is different from other people who like would want to do the research. If you know in advance the situation, you can plan ahead, right? Like probably you need more clinics or hospitals. And then you have some kind of method to randomly sample or something like that. Given that you already started and now you're kind of stuck,
We don't know before.
yeah. I mean, you can keep waiting, or it's a bit problematic if you if at your stage, if you add another hospital, because that other hospital will only have control, because you already finished the uncontrolled.
Yes.
So then you have this kind of confounding of health facility and control versus uncontrolled evidence. So
Yeah.
you have to think about like we can talk after because it's a long discussion, I think. But for other people who would like to do something like that, like it's helpful to know just very roughly like what numbers to expect. Like if you know that this is going to be so different, you might have a different strategy, right? Like you either need more time or you have more clinics, or maybe you do community-based enrollment. Or people who come for non-diabetics reason to get screened for diabetes. I don't know. You can think about other alternatives. Or you do a power calculation where you set the population, like among diabetes patients, if we know that 80% are uncontrolled, you plan an analysis where you know the sample is going to be even like that. But now we can talk about solutions, but now you're just trying to fix the problem, right? So that's a little bit.
And can I share more?
Yeah, okay.
Yeah, so we have the study on food consumption survey that we do with representative from institute. But almost of the kids that we select is the loan accessible.
Is the what?
It's loan accessible because in Lao we have some kids that have just only one season loan. So if the rainy season we cannot go there.
Yeah.
And almost all the research now is like this. It means that we cannot select the thing that very difficult to go or cannot understand. And and maybe our prevalence of malnutrition in the study will give this representative from the randomized selection, but it's still not maybe not fully prevalent.
Right. Yeah, that is a big source of bias, potentially. I mean, you don't know how much bias you have, but that's a big source of bias. I mean, I guess there are options in the design, which again, I think it's too late because we're already doing it. But like, it might be, usually if you're doing a national thing, you might do some cluster randomizing, like cluster sampling, right? Yes. You randomly pick villages and villages. What you could potentially do is pick fewer villages and then concentrate the resource. So if you have to walk, it's easier to walk in one village than to walk in 3 villages. So, like when you go out, you're going out, you stay all day, you come back at night. Like, so you pick fewer villages, but more people. But the hard calculation, you have to like work on that because villages and people are two different things. They're not equally weighted. So villages are always better to have in villages than to have people inside the village. There's a trade-off.
So it means that in the cluster or starting point, something we can select or we should do random. Just pick the village or we can select.
The cluster sampling would mean that you would go into like a province and you would pick villages randomly, and then inside each village you would pick random people. So it's not like you get all the people and today you go to that village and today you go to this village to find her and things like that. But in a village you will find like, that way you go to only a few villages. But the power of those things would come from the village. So the more you can do, but it's a balance of expertise. And the other thing people do is they just say like, look, I have bias. I couldn't go to certain areas because it's only representative of people who have road access. And the people who don't have road access can be picked. Yeah. And actually it can vary, like in I don't know Lao, but like for example in some parts of Sri Lanka where I'm from, the people who kind of live like if they live in the jungle but they live in a place where there's a lot of like good soil and good water, then even when you live in the jungle there's a lot of food that they can go and get from the jungle itself, right? But so those people might actually be better, but then the people who live in the dry area but live far from the road, like it's very challenged, right? So it's not the same. So it really depends. The type of bias and who you're leaving out can vary depending on the environment.
Yes, but we have to report all of these in discussions with you.
Yeah. Yeah, and I mean, it's not just the discussion, right? It's also like your action. If you're estimating prevalence of inadequate vitamin intake and you're excluding the people who might have very poor vitamin intake, and you're going to design your interventions and policies on this number of what percent have inadequacy, and you think that number is actually biased because you have to get the remote people. Right? Like you have to think what direction is unbiased. Like I'm probably underestimating the efficiency. And then the other question is when you get to interventions, how do you have reached those people? Right? Like, so you do have to come up with solutions for that. And sometimes it's very resource intensive. And we did a study in Tanzania that was looking at neonatal neonates. And we had, we went with motorcycles everywhere, but in the rainy season, like we literally put the motorcycle on a boat and then went sometimes you do crazy things to get your data. So, okay, what's the time? Oh, it's 10 o'clock. Let me stop there and let me go to a new PowerPoint. So now we're going to talk math. We're going to go back to data and figures and things like that. All right. Okay. So this is those slides. I skipped a few slides in this last topic, but it's because I wanted to do it in a little more detail. So some of this, I'll give you all the slides, but some of it is maybe more technical than necessary, but I want you to get this idea. And I can say sometimes I have difficulty with this. So hopefully like for me, when I was learning, this was sometimes challenging. So if it's challenging for you, let's do it slowly and let's see what we can manage. So I want to talk about this idea of binary outcome. When you have a categorical or nominal outcome, but there's only two values. And that for kind of public health nutrition, this is so common, right? You have stunting, no stunting. You have disease and no disease. You have overweight and not overweight. We have this kind of binary outcome, binary meaning there's two possibilities only. And so it's somehow like some kind of success or failure. And success, I mean this in a very statistical way. Success is a thing that we are interested in. But sometimes this state that we're interested in can be very negative. For example, a success might be mortality. Like somebody died. Do we want to look at the chance of mortality because of some intervention or lack of intervention or something? Success is just, it's not meaning something good. It just means that the thing we are interested in. That's the event that we are looking for. So it can be disease or no disease. It could be like yes or no. What? Do you brush your teeth? Yes or no? like that kind of thing. Do you have a son or a daughter? There's anytime you have two possible things. There's a technical term for this, which is called the Bernoulli trial, just to let you know. So that is like just kind of one instance. So for example, like if you look at a woman and you say like, okay, she has maybe 3 children, you have 3 separate things that you're interested in. Each one can be boy or girl, right? Like the first one, you have kind of a sample size of 3 with this woman, and the first one can be a boy or girl, second one is boy or girl, third one is boy and girl. Those are independent, right? So we're interested in one of these states. So for example, if we have disease and no disease, probably we're interested in disease, right? That is what we're studying. So whether disease is diabetes or stunting or COVID-19, whatever it is, that's what we're interested in. So I'm going to use this kind of notation. And I think Roger was using this notation as well, but like, let me just write it a little bit. I'm going to talk about probability of disease, right? Probability is the chance for that disease, and it's some number between, what are the values of probability? What's the lowest value? Something can never happen, it has a probability of.
Like you said about exposure, not exposure, and you may be disease and non-disease.
No, we're not going to do it. We're keeping simple. We have no exposure yet. We just have disease or no disease. So the definition of probability, you know this word? I don't know if there's, we lost that. Just the definition of probability. Kelly? Sorry, what is probability? Is there a word? Is it the chance of something?
Probabilities. Is like the chance of something happening, right? Literally,แต่เราสามารถเห็นสถิติได้เนาะ%ได้เนาะที่แบบคือว่าเราเปิดแอปเราก็ต้องที่ตกลงมัน40% probability เนาะ It's an example of weather forecasting using probability of rain.
Exactly. That's perfect. Yeah, so the number, so probability can be like 0%, never going to happen, right? So 0 is never, ever, ever going to happen. 1 means for sure it's going to happen, no doubt, right? So probability goes between 0 and 1. So the higher it is, the more likely it happens. If it's 1, it will definitely happen. And 0, it will never, never happen. So that's the idea. So this P, I'm just going to call it probability. That's my, just to write in a short way. And then, so that's the probability and then disease. So what is my, for example, so this is between, so between 0 and 1, right? And 1. So your probability of getting, cancer, some liver cancer, for example, I actually don't know the number, but probably if you ask me what's my probability, everyone of us can get liver cancer. But yeah, it's yes or no, but the chance of that for me, maybe it's like, I don't know, 0, 0, 1, any liver experts, so meaning 1 out of 1,000 people will get liver cancer, for example, or some type of cancer. Yeah, I don't know the actual probability, you know, or incidence. It's small, but it's not that small. Yeah.
But not very small, but yeah. for the academic area.
What about if a woman has a baby, what's the probability of a daughter?
50.
So it is what number between 0 and 1? Which is 0. 5. Yeah. So if I have a child and then 0.5 chance it's a daughter, otherwise it's a son. Like that. Yeah. Maybe. Okay. Might be there's some gender imbalance. So technically, actually, this is a little bit greater than 0.5 in reality. So, but you get the idea, yeah? Okay. So then because there's two possibilities, if this is true, right? Then the opposite is probability of the son, right? Is then what? 0.5 also. Because either if you have a baby, it must be this or this. Okay, technically speaking, there's some genetic anomalies and you might have a, but let's pretend this is equal chance, male or female. So the way you get this is 1 minus the probability of the daughter. So 1 minus 0.05 is also 0.5. That's how you mentally did it. It made sense, but mentally that's what you're doing. You're doing a calculation like this. So that is what this is saying here. There's a probability of disease. So if you want the probability of no disease, you go 1 minus. So if my probability, here's another one. In this sample, you have a child under 5 stunting, right? Maybe in this population, it's 0.3. They're 30%. Yeah? So then probability of no stunting is what?
Yes.
0.06.
Oh, 7.
Does everybody agree? You agree? Because it's 1 minus this. It's 1.
Maybe 0.6 because some holidays.
Fail. You have to sit outside.
Just want to make noise.
Okay, so good, yeah. So we want to know these sort of things all the time, right? You can think of probability like risk, right? What is the risk of something? It's 30% or 0.3, which means that the other 70% are not stunted. Okay, so a lot of times we want to estimate this, right? So when we're thinking of prevalence of something, we're trying to estimate a probability. That's that P and P hat and everything Roger was always talking about was this. So let's make it more, let's go more. So Dr. Kate showed this kind of table, didn't she? I think kind of this, and Roger as well. Kind of, you have kind of 2 different scenarios, and you might have 2 different exposures. So say that you have 200 participants in an RCT, and these 200 participants can either get a control or a placebo, or they get some intervention, right? So these 200, so for example, we talked about giving iron during pregnancy. So these are the control or placebo group, 100 women. And in the intervention, you have 100 women. And then we look at the disease. So maybe this is malaria, right? So have malaria, don't have malaria. So the 100 women who get the placebo, 35 of them will get malaria. That means 65 don't get malaria. An intervention, you have 100 women, 25 get malaria. That means 75 don't get malaria. So then the total is 100, and then that's your 200 women. So you can take your sample and kind of just put them in the right category. They're receiving this control treatment and they get the disease. They come with the control treatment, they don't get the disease, and so on. So classified numbers, right? Is that okay? that table, how we make that. This thing, this kind of, it's like a cross tab. If you ever did an SPSS or Stata, this is a cross tab. Sometimes they call that kind of just looking at the relationship and just looking at the numbers. What sample is there? And what I'm doing here is I'm just adding, right? So in control, I had 100 women. That's the sum. Intervention, I had this and this. The sum was 100. The grand total is here in the corner. And so if I don't know who is in what group, if I don't know who is control, who is intervention, I'm blinded, then all I know is who has the disease. How many have malaria? 60. Like once you tell me the treatment, I can say 35 here, 25 here, but the total 60. So 60 out of 200 are getting malaria, but it looks like there's more when it's a control compared to the intervention, right? So this is where we start building our hypothesis. We want to say, okay, maybe this intervention is reducing the risk of disease, right? That's often what we want to do. We want to reduce the chance of a negative outcome. So we're going to do some calculation on this, and I'm going to introduce a new notation. So now I had probability of the disease. Now I put this vertical line. Can you see that? And then I have intervention. And this vertical line means that it's conditional, or it's given, or you're saying it's among a certain group. So the disease among the intervention. And then I want to know the risk of disease among only the intervention. So I don't want 200 women. I just want the 100 in the intervention. So if I look at who is in the intervention, so think of this as like kind of like among, or given the scenario, given that they have the intervention, I have only 100, intervention. I have 100 women. How many have the disease? 25. So 25 out of 100 is 0.25, 25%. So that's the kind of your risk, your chance, your probability of a disease if you get the intervention. Is that okay? When I was in school and I first learned this, like I had such a hard time with it. And I thought to myself, maybe if I never do this, it's okay. I can do anything else. I can't do this. And unfortunately, I got this job and now I have to do it all the time. So it's okay if it takes some time. So, okay, here's another example. So what's the probability of disease among the control? I have 100 women who get the control. 35 have a disease. So 35 over 100 is 0.35. Okay? Okay, so then you tell me, what is the probability of no disease among the intervention? What did I say? Intervention, right? It's called an inter. So it's how many get the intervention? 75. 75 is the no disease, the top. Out of 100, right? So the intervention total number is the bottom, and then the number who have the no disease, the condition, is the top. And yeah, because it goes as so that's great. And notice 0.75 is 1 minus this one. So this one is among the intervention, the disease. If you go 1 minus, you get no disease among the intervention. So you need to like have this kind of conditional statement the same, and then you can have this or the opposite, and they should sum to 1. So it's kind of a way to check yourself. Epidemiologists love this stuff, so you have to get used to it. Dr. Kate will say numerator and denominator. They use that word a lot. So it's just anytime you do a division, Like the top is numerator and the bottom is denominator. Are you familiar with this word? Yeah, sometimes, yeah. Am I writing big enough? You can read. Yeah, you can see properly, right?
On the further side, they might have read as a refrigerator.
What?
Numerator.
Dr. Kate will use these words all the time because epidemiologists think a lot and they spend a lot of time thinking about these words. Because the denominator is basically everybody you are interested in. In this case, everybody you're interested in is all the people who get the intervention. And that's your denominator. And then the numerator is the one who has the situation you are interested in. So here I'm interested in healthy, like no disease. And so that's the numerator. And sometimes when people talk about bias, so if you ask an epidemiologist like Kate, like she will say like, and I think she used that in one of her slides, she said like these survival bias, those people, if you live, then you get counted, and if you die, you don't get counted. So they were saying the survivors are included in the numerator, meaning those are the cases you detect. So they use that word all the time, like what is the numerator, what is the denominator? And who should be here and who should be here is not always a simple idea. Like I think when you teach students, they get very confused about these things sometimes. And sometimes this is where the bias is happening. And you want to kind of understand when some scenario is happening. For example, that the road is terrible and you can't go to certain parts of the community, like Hashimi was saying, then what is happening? Like, are you losing denominator and you're losing numerator? If you're losing one more than you lose the other, you know, something like that. So that is where the bias is really starting. So, okay. Let's see. So what is the one? No disease in the control. Okay. Sometimes they say this is like given or among, let's just say among control. It is 65. It's 65 out of 100. Yeah. So no disease among the 100 women. In the control group, 65 have no disease. So you get 0.65. And notice 0.65 plus this one, 0.35 is also equal to 1. You can always check your work. The other thing, and maybe you remember this from last week. Do you remember how Roger was talking about sensitivity and specificity? And those things are, and those are very complicated. Sometimes they're difficult concepts. But this 2x2 table, you know, like 2 rows and 2 columns, you can call it a contingency table, you can call it different names. But like there are so many things people do with this table of different ways to calculate different numbers. But it takes some practice. Okay, so important thing to remember, these probabilities have to be between 0 and 1. So if you calculate a number more than 1 or you calculate something negative, something is wrong. So you have to go check the work. Okay, now there's this idea of independence. So we'll leave that alone now. Independence is a theoretical idea, and it's something that you can understand intuitively. So let's try it. You have a treatment and you have a disease. Are they related? Right? You hope so, right? You develop some treatment for the disease. You hope that it's related, right? Like that treatment can reduce the disease. That's what you want, right? That's what we are all trying to do. And so if they're independent, it means that the treatment has no effect on the disease. Like there's a treatment, it does something, it doesn't change the disease at all. That is sort of like a null hypothesis situation, right? The treatment has no effect. The chance of disease is the same, whether you get the treatment or you get placebo. You know, the treatment is just useless for the disease. That is the idea of independence. If you want to say it in a very technical way, and we want to be rigorous, right? Like in research, we want to be rigorous. The way of saying this is like this. The probability of disease among the intervention, if you get intervention, is the same as the probability of disease if you get control. You have a certain chance of stunting, and the chance of stunting is the same if you get the intervention as if you get the control. That means the intervention is useless. It didn't change your risk of stunting, right? That is what independence is. There's an intervention, there's a disease, they are independent. That means one is not helping the other or changing the other. That is the concept. So same thing if you want to talk about no disease. Sometimes we want to talk about healthy. Like the chance of being a healthy child, given that you get the intervention, is the same as the chance of being a healthy child if you're controlled. Okay, again, the intervention versus control, that is just not making any difference for your chance of being healthy or having disease. So now we talked about this last time. We talked about it in a few different scenarios. There's this thing called relative risk, right? And risk means that every outcome has a certain chance. There's very few outcomes where the probability is 0, and very few where the probability is 1, right? Like most things have some chance, it's not certain. Like every child has a chance of having stunting, right? And what you want is, in different scenarios, we want to change that chance. So if it's a disease, we hope to reduce the chance. And so one way to think about it is not to say like, okay, does my chance, my probability become close to 0? That's not going to happen, right? Sometimes, can we make stunting 0? I hope someday, but not anytime soon, right? Like we're going to have, maybe if the population has, 25% stunting, if we can reduce it to 20, like we're happy, we reduce the risk. So how do you measure that? You measure it relatively. There's a certain probability of having, with no intervention, there's a certain possibility of disease. What's the chance of stunting with no intervention? Maybe in the population it is, okay, let's use it here, 0.35, 35% stunting with no intervention. But if you do this intervention, you find that this chance of stunting is reduced and it becomes 0.25. So you can kind of take the ratio, just divide them and say that the chance of having stunting is only 71% if you have the intervention compared to standard of care or just no intervention. So you want this number to be as small as possible, right? The more effective your intervention is in reducing the disease, the smaller you get this number. So this calculation is called relative risk because you're saying, what is the risk of my disease relative to kind of the comparison group? Standard of care, no intervention, whatever it is. My risk is reduced. This number should be less than 1. If it's the same, if these two things, if disease and treatment are independent, then these two probabilities are the same. Which means you divide 0.25 by 0.25, you will get 1. So anytime you have a relative risk of 1, it means that your intervention or your exposure is having no effect on the outcome. If it's less than 1, you're reducing the risk of the outcome. If it's more than 1, you are increasing the risk of the outcome.
Less than 1.
What's that?
Less than 1 is good.
It depends on how you define the outcome. Because for some people, the outcome is, mortality. So if you can reduce mortality, it's good. If it's like being healthy versus underweight, you want to increase the probability, right? So it completely depends on what you, like here I called it disease. But sometimes you want to be more positive and you want to have that be health. Or it could be a successful pregnancy, or it could be, a baby of healthy weight, or, anything like that. So whatever this is that you're looking for, are you reducing the risk? It's below 1. Are you increasing the risk? It's more than 1. So this number, relative risk, is different from probability because it's always comparing one situation to the other. It's possible that this number can be 0, but maybe your intervention completely eliminates the disease, like completely, perfectly. Then relative risk would be 0, right? I mean, good luck if that can happen. That's great, but I've never seen it. But you could make this very, very, very small. You have a very effective intervention, right? Or your intervention is so bad and it like makes it totally likely of getting the disease. Then this number can be basically any large number, right? So this relative risk will go from 0 up until forever, infinity. So those are the possible values. Relative risk anywhere from 0 to any number that's high. So in this particular scenario, I looked at probability of disease with the intervention compared to probability of disease when you get the control. This one was 25%, this one was 35%. I took the ratio, I got the 7.714. So if you kind of think about it in the other way, the intervention reduces the risk of disease by, it's a difference, 28.6%. So the more you can reduce the risk, the better. And sometimes this number is what people say. Vitamin A supplementation of under 5s reduces risk of mortality by 30%. Something like that. That's often what we say, right? And it's significant somehow. So again, if these two things are independent, the probability of disease is the same for intervention and control. You have number divided by same number, this number is 1. So that would mean that the intervention or the treatment and the disease are independent. That means the treatment has no effect on the disease. This, if you want to write a null hypothesis, you have 2 choices. You can talk about these 2 probabilities and say they're equal, or you can talk about the ratio of this relative risk and say that's equal to 1. Both of them are a good null hypothesis, and they mean the same thing.
Yes, related with race and on ratio.
Oh, it's coming.
It's not.
Oh, yeah. So, okay. Are you very comfortable with this? Are you guys okay with this? So relative risk, I think, is a little bit more intuitive. Like, imagine that you were looking at my chance of lung cancer, right? Everybody can have a chance of lung cancer. It can happen to anybody, right? But imagine if I live in a very high pollution area, then my risk is going to increase. How much does it increase? 2 times? Because I live in high pollution? That means my relative risk is 2. I double my risk of getting lung cancer in this polluted environment. Maybe it's very, very, very polluted, right? And my risk of lung cancer goes up by 5 times, then my relative risk is 5. I have 5 times the chance of getting lung cancer in this very polluted environment. So it kind of makes sense, right? Like it's like a multiplying. How much more does your risk become with a bad exposure? How much does your risk reduce with a good exposure? Like that. Yeah?
Yes, and we interpret also not saying about size of a difference, but increasing by percentage.
Yeah, you can say that. Yeah. So if it doubles, if my risk of cancer is doubling, you can say it increases by 100%. It's a little bit harder, right? Because you're like minus, like doubling is 100% and tripling is 200%. So sometimes it's just easier to say it's double the risk, right?
The relative risk is 2.5, something like that. It's a 150%.
2.5 would be, you multiply my risk by 2.5 times, which is an increase of 150%. Are you okay? We'll practice this in a lot of ways, but now we bring up this odds. And odds is a little bit more like I find relative risk a very like natural way to communicate. How are we? Okay, good. Odds is a little bit less natural, but it's very useful. And you find this, and this is important because a lot of us want to do logistic regression. Anytime you have a binary outcome, like disease, not disease, stunting, not stunting, anemia, not anemia, we want to do logistic regression, and we're going to need odds. So let's do odds, and see how we go. So odds, the odds of something is the probability of that times divided by the probability of it not happening. It's very not intuitive. So, in fact, the people who are most familiar with odds are the people who like to gamble. Like if people go to a casino or something like that, they use odds, or if they watch like horse racing, things like that, people use odds all the time. I'm not very good at gambling, so I'm not that familiar. But yes, if you do like horse racing or you're doing betting like who's going to win the World Cup, people use the word odds all the time for that kind of thing. So if you're more familiar with those kinds of things, then maybe odds makes sense. So odds is what? It's the probability of something divided by the probability of it not happening. This is not odds ratio yet. So let's say, let's go back to the son daughter, right? Like, let's just say like your child can be male or female. Let's just use that, right? So this child is coming to the clinic, and is it male or female? So roughly, it's not exactly, probability of male is 0.5. The odds of child being male, odds male, is equal to this probability, 0.5, divided by the same probability. And here, so this is 0.5 divided by, this is just 0.5 again. The odds is 1. So when something is like it can be this or it can be that. Like if I take a coin and it comes up top or bottom, and I just like throw a coin in the air and I see like its top or bottom side, like it can be equal chance, right? Equal chance of this outcome or equal chance of that outcome. The odds is always 1. If the odds is less than 1, it favors, it goes against this. So like, for example, let's do another one. Let's finish this. Probability of, let's say, funding. Yeah, 0.25. So odds of something. It's going to be 0.25 divided by 1 minus 0.25, which is 0.25 divided by 75, which is like 1/3, right? 3/3. That is the odds of something. So it's another kind of measurement, and the reason why we care is when we try to do regression with a binary outcome, we will use odds. And it's not as easy to think about odds, but we'll get used to it. If the odds is greater than 1, so here this is something where the probability was less than half, the odds becomes less than. If it's more likely to happen, like maybe it's the probability of not sending, right? Then it's 0.75. This odds would actually be 3, be greater than 3. So that's what this sentence means. If the odds is greater than 1, that event is more likely to happen than not happen.
Next slide. Likely to be something. So
It'll be 3.
Yeah.
It'll be the exact opposite.
33% attractive.
Yeah, so probability of no stunting.
6%.
No stunting, if probability of stunting is 0.5, then this is equal to 0.75, right? So odds of no stunting.
0.5 divided by 0.25
Yeah.
divided by 76. You said sorry.
And notice how this is 3 and this is 1/3.
1/3.
That's the exact reciprocal. That's called reciprocal. It's upside down. Like one over this will get you this.
3 times.
Yeah. So odds. So again, odds is something about probability, so it'll never be negative. It has to be 0 or up, but it can be 3. It can be basically infinity. So odds has more possibilities. So odds are also nice because probability. When you do regression, you know, X can change any kind of amount, which means Y can change any kind of amount. And if the Y is a probability, you're in trouble because probability has to be between 0 and 1. So normal regression is not going to work for probabilities, for these kind of binary outcomes. That's why we have to go through odds. We need something that can be any number. It can't be negative, but it can be any number except negative.
Yeah. Go 3 for this. For the no stunting.
The odds. Right?
Yeah. No stunting odd equal 3. What is it?
The odds of no stunting. So the probability of no stunting, if this one is 0.25, this is 0.7, right? And so then the odds is this one divided by 1 minus the same number. So 0.75 divided, this is 0.25. So if we divide that, that becomes 3. And the idea here is that there's only 2 possibilities. You have stunting or you have no stunting. You have 1 odds and this odds. And if these numbers are related, right? This is 3 and this is 1/3. So 1 is always the reciprocal of the other. Like 1 divided. So 1 divided by this will give you this. 1 divided by this will give you this.
So we asked how to interpret it.
Yes.
People will just say the odds of a certain event are this. So if you are doing gambling and you're betting on who wins the World Cup, the odds of, I don't know, Italy or something winning. I don't do sports very much, so I don't know. But the odds of Italy winning are 0.7, right? And so you can kind of calculate it's related to the probability. So sometimes when I see odds, and you have to be very careful, like when I'm thinking about it, I think of odds a little bit like probability, right? The more odds of something, the more likely something is going to happen, right? But it's not exact. It's not like exact, but the idea is there. Like more odds, the more likely something is going to happen.
So that is why we just
No, that is relative risk. If it's 3 times the chance, it's relative risk, not odds.
okay. So
Yeah.
more likely 30%. 33% compared to
Just call it odds and like don't try to just think about it like it is hard to think about, but like when you're trying to interpret your result,
yeah.
just think about it sort of like, okay, if the odds increase, the chance of this thing is going to increase, right? But it's not exactly like 1-to-1, but the general idea is there, right? If odds increases, the chance of something increases. When you write, like when you're writing a paper and you want to be very rigorous and sharp, like use odds. Don't say chance, don't say risk, don't say probability. So specifically odds.
You know what? In Lao, we don't have a perfect term that is translated on that.
I know. It's a technical term. It's a mathematical term. Yeah. So maybe you keep saying odds.
And we'll get it in the
Yeah.
We have to try it on them.
Okay. But wait. Okay. Let's see how. Okay.
Yeah,
Okay. I'm gonna say one more thing and then we take a break. So then you can think about this while you have a little bit of like break. So we talked about odds, right? Now we have another thing, odds ratio. Odds ratio is a next level issue. The odds ratio it's a ratio, meaning you compare two things, one thing divided by another, that is ratio. Ratio is something divided by something. So you want to do an odds ratio, it's the odds of something divided by the odds of something else. So this top one is the odds of disease, the top part of this, the numerator, that's that word they use, the odds of disease if you get intervention. The bottom is the odds of disease if you get a control. So what you want is the intervention, because odds is a little bit like your chance of getting the disease, right? What you want is your intervention to reduce the odds. You want this top one to be less than the bottom one. If the disease is a bad thing, then this top one, hopefully the intervention will reduce the odds of getting the disease compared to control or no intervention. And so we can calculate again, we know this probability, we know this is the same probability. We know this probability from the previous slides. This is the same. Calculate, and you get a number. And again, we're comparing it to 1. If it's 1, it means the odds of disease is the same, whether you get intervention or control. So intervention of control is useless. Like you have the same chance of the same odds of getting the disease. So if it's 1, it's like the treatment, it's just useless. If it's less than 1, you have reduced the odds. So that's good. You have a reduced odds of a disease. So if it's less than 1, actually we're happy. If it's more than 1, you made the situation worse. Your intervention is increasing your odds of getting the disease, in which case you really don't like it. And then, so you see where we're going. This is when the odds ratio is equal to 1, it means that the treatment, it's not working, nothing is happening. It's the null hypothesis situation. Odds being 1. If it's significantly less, now is 0.619, is it significant? We don't know. We need a confidence interval, right? We need to do statistics to find out is it significant, but it looks a lot less, right? So if it's 0.61, let's say it's 0.62. So we're just rounding to 0.62. So that is a 38% reduction in your odds of a disease if you get this intervention, which might be a good thing. Yeah. So again, this odds ratio. So this one question, odds ratio will never be negative. It can be 0. Yeah, it can be 0. If the intervention totally makes the disease like 0, no disease whatsoever, you can have an odds of 0. But in real life, that will never happen. But conceivably 0, not negative, 0, but anything higher, right? If you double your odds of getting a disease from this exposure, then this would be 2. It can be triple, it can be quadruple, it can go up to infinity again. So again, odds ratio is another number that can be any number as long as it's not negative. So, and that's why we want this. We want to use this for regression, and that's what we're going to do. Okay? Should take a break, and we'll come back to this. Okay. Are we ready? Shall we go for it? Okay, let's do it. Okay, we're going to just a few more slides of this, and then we are done with this for a little bit. I will go back to Dr. Kate's slides of topics and talk about cohort studies up until lunch. And then after lunch, we'll do some more examples and more statistics. So we'll hop around and we'll see. Again, I was not planning to do all this stuff, without Kate, so you're getting the improvisational version. But I think it's okay. How do you feel? Some new ideas, probably. Okay. All right, let's go for it. So chi-square. Chi-square, Professor Roger did chi-square, right? So chi-square is in this situation. So we have the same situation as before. We have 100 women in control, 100 women getting intervention, and we're just seeing who is getting the disease, who's not getting the disease. The idea of chi-square is to test this relationship. Are these truly related or is it independent? So that word independent, right? If the chi-square is actually a test of independence, the things that are independent are the treatment and the disease. So the null hypothesis is like this. So we're saying that there's a chance of disease if you get the intervention, and it's the same chance if you get the control. Basically, the chance of disease is just that chance, regardless of intervention or control. That's the null hypothesis. That is independence, meaning that whether you're intervention or control, you have the same chance. This intervention is not helping in any way. And then the alternative hypothesis is going to be that somehow these probabilities are different. And when we looked at it, we said, okay, yeah, in our data, these probabilities are different, right? Here you had 35%. In the control group, your chance of disease was 35%. And in the intervention, the chance of disease goes down, it's 25%. So you think it might be good, right? But is it statistically significant? Or is it just by chance? So that's what we need to know. That is what the chi-square is. And yes, there are formulas and you can kind of ignore it. But the idea is the same for any statistical test. Every statistical test will take this null hypothesis and say, let's assume that's true. If so, what kind of data are we expecting? If that's true, this is what we expect, and this is what we truly see. And how are they different? And it's just one formula that takes your expectations, if the null hypothesis is true, and your true data, looks at the deviation between the two, the difference between the two, puts it as one number. And if that number is very big, it means your data are very different from the null, which means that it's probably the null is not correct, right? If it's kind of small, if whatever number you get this test statistic, it's just some number. If it's relatively small, then maybe it's kind of your data are consistent with the null hypothesis. There's not, a lot of deviation, so you don't reject the null. That's the principle. So you calculate, and there's a formula, and Stata or SPSS or whatever your software you're using, so you don't have to worry about it too much. But that's the idea. Basically, we're taking something, your data is the observed, E is the expected, that you expect if the null hypothesis is true. How different are those? You square them, you add them up. If it's a big number, then there's a real deviation. That's the principle behind most statistics, actually. And then there's this thing called degrees of freedom that have to do with this number of how many rows and how many columns you have. Again, like Roger mentioned, that you don't need to know it necessarily because your software will spit it out for you. But for anyone who is just wondering, what is this degree of freedom? I can just tell you very quickly. So, I have 100 women in control. I have 100 women in intervention. And if I look at my whole sample, I have 60 women who have the disease and 140 women who have no disease. So imagine you didn't know these numbers. You just know who has the disease, who doesn't have the disease, and you knew there was 100 in each. And then I told you this number is 35. And I left this one, and this one blank. If I told you this is 35, you can calculate every other number, right? Because 35, that means it must add to 100, must be 65. And then this one must add to 60, so this one must be 25. And you just do some math and you figure it out. Which means if I tell you one number out of 4, like I have determined the whole thing. I had one number that was free and everything else is not free. 1 degree of freedom. So a 2x2 table, number of rows -1, number of columns -1 is the product of 1. You have one number. I can tell you one number and everything else is determined. One number is free, the other ones are not free. That's the whole point of degrees of freedom. We use that word all the time. You see it in the data output. That's the principle. Sometimes in Stata, or you use SPSS, or you use another R or some other software, sometimes you will see a likelihood ratio test, or sometimes they say LRT for likelihood ratio test. It's similar. It's asking the same null hypothesis. So if you see chi-square, okay, that will answer this type of question. If you see this LRT likelihood ratio test, it's asking the same question. So that's just so you know. And then there are some situations where, remember I said this is what you expect under the null? Sometimes what you expect is very few. Like maybe the disease you're looking at is very uncommon, right? Like you're looking at, again, like a cancer or some very rare genetic disease or something. So for those, sometimes the number you expect in any category might be small. And these kinds of statistical tests, they need a certain sample size. Not just overall sample size, but also the number of cases that you're seeing. The cases or the non-cases, the disease or the non-disease. If there's some group that's very, very small, sometimes these statistics are not very appropriate. And it's a very rough thing, right? Like it's not like there's one specific rule, but in general, there's something called Fisher's exact test. I know some of you are familiar with that. It's a non-parametric method. So when you have some rare event or something where you have very few numbers in one of these 4 boxes, if the number is very small, sometimes you can do this Fisher exact test. It has the same null hypothesis, the same interpretation of the p-value. The calculation is a bit different because it's dealing with rare events. So it's 3 different ways to do things. You will see them like when you're reading a paper or something, just know that they're trying to all answer the same question under certain different scenarios. Is that okay? We will do more chi-square, I think, together. So it's coming. So let's just end this part with an example. So this was, actually, this is from a very nice textbook. Now it's a few years old. I think it came out in 2017 or 2018. I can send you the book. Called Nutrition and Health in the Developing World. And it has some really nice, I'll send it to you guys, because I have the PDF. So this is looking at neonatal mortality. And it is looking at relative risk in 3 continents or 3 regions. So we have Asia, we have Africa, we have Latin America. And it's looking at neonatal mortality is our outcome. And what it's looking at is size of gestational age. So small for gestational age. So let's see, how do it's sort of like stunting, if you think about it. It's stunting, but in utero. So, oh gosh, I'm going to get this right. So so if you look at the size of the baby, when it's born, it's a little bit deceptive, because if you look at situation at birth, there's 2 possible problems. One is that a baby is preterm. Then of course you expect a baby to be small if it's preterm, right? Or it's not growing well in utero, right? So when you measure a baby at birth, there's really 2 possible problems. One is just preterm, and it's normal growth, but it came too early. Or it's not growing according to that gestational age. There's some growth restriction, there's some problem. It could be nutritional, it could be other kinds of things. So small for gestational age, it's a problem. And so it is looking at severity. So it's looking at, is this child, depending on when it is born, what is the gestational age at delivery? Like, is it growing according to a healthy growth curve in utero? Is it small for that gestational age? Or is it extremely small for the gestational age? So what we expect, or what you hypothesize, is if this baby is not growing well in utero, the risk of mortality, of neonatal mortality, is probably higher. Right? It makes sense? Right? So these babies are extremely small. They're not growing well during pregnancy. These babies are somewhat small, and these are okay, normal. So our hypothesis, if it's neonatal mortality, we expect worse outcomes, greater risk in this group, and a medium risk in this group. And then, this is kind of the comparison. This is the healthy group, right? So this is, it's a little complicated, but this is the sort of thing you're going to see when you're reading things. And this is how we use an idea like relative risk. So what we're doing is, in the healthy population, where the baby is growing well during pregnancy, the fetus is growing well during pregnancy, we have this as a comparison group. Then we look at the risk of mortality if a baby is small for gestational age. So we take Asia, if a baby in Asia in general is small for gestational age, what is the risk of mortality compared to if that child is healthy during pregnancy, if the fetus is healthy during pregnancy? So what this means is that there's a 20% increase in the risk of mortality if the baby is small for gestational age. And if the baby is very small for gestational age, compared to a healthy child in Asia, if during pregnancy the fetus is growing very slowly, there's a 91, compared to a healthy growing baby, there's a 91% increase in the risk of mortality. For Africa, it's different, right? So compared to a normal, well-growing African child, if you have a small for gestational child, it's a 27% increase in the risk of mortality. And then if it's very small for gestational age now, it is, you can say that the risk has more than doubled, right? This is more than 2. It's a 123% increase, right? So this is a multiplier. So whatever the risk was in Africa for a healthy child, and we know the risk is a little bit higher in Africa, they have more mortality for children. It is more than doubled if that same child has small for gestational age. So we're looking at a condition which is a small for gestational age, so inadequate growth during pregnancy of the fetus. It is increasing the risk of mortality after a live birth, right? So that's what we're getting at here. And what's interesting here is that the regions are not the same. So being very, very small for gestational age will almost double the risk in Asia, almost double. Here it's a little bit, in Africa, it's a little bit more than doubled. In Latin America, it's 4 times. So if you take a child in Latin America that is growing well during pregnancy, the fetus is growing well, compared to a healthy one, a small for gestational child has 4 times the chance of mortality in Latin America. So it tells you that there's something different, right? There's something going on. So what are the causes of neonatal mortality? Like, there are many causes, right? Health of the mother, the conditions around labor and delivery, the availability of, obstetric care, the qualifications of the doctors and the nurses, the equipment, availability of drugs, of blood. Like, there's many, many reasons for neonatal mortality, right? But certainly there are regional differences in that risk. That is what it's saying. Okay, so that's relative risk. It's a multiplier. 4 times the risk, more than 2 times the risk, a little bit less than 2 times the risk. So small for gestational age is a reasonable predictor of neonatal mortality. That's what we're finding. And the more small a baby is, a fetus is until delivery, the greater that risk of mortality. relative risk now is a multiplier, right? So if we say 4 times the risk, one question you should ask is, well, what is the baseline risk? You're saying the risk is more than 4 times greater, but what was the original risk, right? The original risk is actually down here. So that is also interesting. So in Asia and in Latin America, we have less neonatal mortality. So in Africa, there's actually more neonatal mortality. So this is number of deaths per 1,000 live births. So Africa, it's higher. And then it gets multiplied as the small for gestational age is increasing and becoming more severe. So even though Latin America, if you have very small for gestational age, the risk is being multiplied by 4, the baseline is actually relatively low. So when you're thinking about like, okay, how do I think about this data? Well, one, okay, this multiplication factor, something is happening. The small for gestational age is really a risk factor when it comes in Latin America. It's a risk factor everywhere, right? In every continent. But in Latin America, it's somehow more. What's happening? You can start asking questions. Why is small for gestational age really increasing risk in Latin America? And you can do some work on that. But then if you're also thinking, where is this all a problem? In general, in Africa, the baseline kind of neonatal mortality rate is higher than other places. So when you multiply a higher number, but only by 2, it's still a lot, right? So it's not an absolute value, it's a relative risk. Compared to what? Compared to the healthy. And that baseline risk might be different from place to place. So just kind of keep that in mind for interpretation. Any question?
Any questions?
Many question? Are you satisfied?
So if we compare by different times, higher times, lower, that means that we are talking about the relative risk.
Yes. Your chance of neonatal mortality, how many times is it increasing? When you say that, I double my risk, I multiply my risk by 4, I quadruple my risk like that. That's always relative risk.
It doesn't matter what the baseline is.
It should matter to you, but for the interpretation, no. The interpretation is, it doesn't matter what the baseline is. Is it a rare event? Is it a very common event? Doesn't matter. But for you, like, probably it matters, right? You want to know what the baseline is, and if you increase, like, so it is important to know. So say you take some very, like, unlikely thing, I don't know, like having an airplane crash. And if you do this, then maybe that's not a good, it's a very scary example. So I'm trying to think of something like,
The domestic faults.
what?
Yeah, the fault in others.
What?
The fault going down.
Yes, like, what is my chance of like falling down right now? Okay, it's very small. And I don't know, if I pick this up, maybe my risk will double, but I'm not gonna fall down. Like, it's very, very small. So if it's a small risk, really, really, really small risk, like, and you double that risk, you think that's terrible, but actually it's still, if you double a small thing, it's still pretty small, right? You don't need to panic or develop a public health intervention for something that is like so unlikely. So even if you double, even if you make the risk 5 times, like 5 times of something so unlikely, okay, that's fine. I mean, you still, maybe you want to avoid whatever it is, don't do it. But if you have something much more common, like neonatal mortality, and you see something that is multiplying something by 2, okay, that you need to take some action, right? This means that, like, you need to do something to prevent small for gestational age. If you want to make progress in reducing neonatal mortality, there are many things you can do, but one of them is to think about why small for gestational age is happening. Is it poor maternal nutrition? Is it lack of antenatal care. Like, what is it? Why is this happening? So in order to reduce this risk, right? So, okay. It's okay. That's it for this section. So we can go to the next thing. Any questions? Any thoughts? Do you read papers? You see relative risk? Okay. I'll send you guys this book and then you can see lots of it. You say thank you. I hope you mean it later too. Okay. Okay, for the next half hour or so, let's talk about, I think this is where we are. I'm gonna try to make some good progress. Yes. So we're gonna keep moving on observational studies. I'm gonna talk about a lot of things. This is an extremely long topic. Yeah, so we'll see how we do. So some of this I think explains a lot, and we don't need to explain a lot of things. We're talking about things where we move beyond description and we want to look at relationships between things. And in observational studies, then we're not trying to control, like providing a treatment, providing an intervention. Usually we're looking at exposures. The exposure just happens. So the exposure can be something environmental, like, you know, you're exposed to pollution. The exposure can be a health behavior, like somebody is smoking, somebody is eating an unhealthy diet. It could be anything like that. So that is what we're trying to do, is try to develop and build evidence for a linkage between some kind of exposure and some kind of outcome. So there's a lot of words that we use, right? So we say the exposure is like the predictor. It's like when we do a regression, it's the X, right? It's the horizontal axis if we make a graph. The outcome is the thing we're truly interested in. That is the stunting, that is the disease, that is the mortality. And that is the Y. So that's usually the vertical axis if we're making a graph. And so what we want to do is build a kind of evidence or not for that question mark. Is that arrow, is it reasonable, is it causal? And there's lots of things like this. So you want to kind of have ways to measure each thing. So looking at smoking and lung cancer. This is a very common example because this is the sort of thing you can never do RCT, right? You cannot say you smoke and you don't smoke. Like that is completely impossible. So you can never do an RCT for smoking. And in the US, this was a big issue several decades ago because tobacco was a very strong industry, right? They have a lot of power and people from public health, they came and they said smoking is unhealthy. It's making cancer. And the companies will say what evidence do you have? Our cigarettes are very healthy. You don't have an RCT. You can't prove that how can you prove that we are causing cancer? Because it's not an RCT. So then it's people were stuck and there was a long debate to make this argument that yes, smoking actually causes harm and increases the risk of cancer. So it was a big kind of debate, and being able to fight it with evidence that was not RCT in order that you could change policy. Now we have warnings on cigarettes that say this can cause cancer, this is harmful for pregnancy. There's a lot of warnings, but those things were not allowed because you couldn't demonstrate that smoking was harmful. So it was a lot of work from public health and health people in order to change the laws and change the policies so that there's warning and there's public health campaigns against using cigarettes. So one thing you can do, so there's different kinds of statements that you want to say. Sometimes you just want to show a linkage, right? Other times you want to be more specific, right? Maybe you want to talk about dose. And you want to be more specific, is it smoking, any smoking? Is it smoking a certain amount? if you want to really build evidence, maybe if you increase more and more smoking, then you should have more and more risk of disease, right? That would be a very nice argument if you're trying to show a causal relationship. And then you might want to say exactly how much. You increase the odds by one, times 1, times 2, or times 27 compared to no smoking, right? So this is a much more specific thing. So, okay, so then what you need in order to make this relationship is you need someone who has the exposure and someone who doesn't. So you have smokers and you have no smokers, like non-smokers, and then you want to see their disease outcome, right? And so that way you can there's a comparison group. And so none of these things are 100%, right? There are people who smoke who are fine, they're healthy, right? Some smokers will get cancer, some, but many don't. And then there are people who don't smoke at all, but they still get cancer. And then there's some who don't smoke and they don't get cancer. You get every possibility happens. So if it were 100%, right, every single smoker gets cancer and non-smokers get no cancer, it's easy, right? The problem is that it's not that easy. It doesn't happen that way. So you can kind of make these different categories. Are they exposed? Are they not exposed? Exposure here means they're taking cigarettes versus no cigarettes. And then do they get the outcome? Here it's cancer. Yes or no can happen in either scenario. And so then we do this kind of contingency table that you saw in the just previously. We can kind of count the numbers in every scenario and kind of work with this. So in the grand scheme of things that Dr. Kate first introduced, there was all these kinds of epidemiological studies. Now we're getting into this analytical situation where there is this kind of comparison group and you can look at how one thing relates to the other thing. And then the distinction here between observational and experimental is whether people can assign the exposure to participants. So if you can assign the exposure, you get, you get clumpy nut and you don't, for example, and then you look at child malnutrition. Then if you can control that, then that would be an experiment. And if you don't, then this will be some kind of observational, oops. Yeah.
Can you clarify more for the quasi-experimental and experimental?
These two? I think it comes in the next topic, so we'll talk about that. Yes, sometimes quasi is when you can't randomize, but you can it's sort of like randomization.
Is the wider convenience?
No, not necessarily. There's some really cool study design. Oh, when we get to the next section, we can show you. There's some things where it's like random, but not quite. And some people do some very clever, there's some very clever study designs. People are always coming up with new ones. When we get to that topic, we can share a few. Right now, we're going to live here, up here. So you might do observational for many reasons. One obvious one is ethical reasons, right? You cannot ask somebody to smoke. It's terrible, so something like that. You can't deny people certain things, right? Like if you have malnourished children and you say you get plumpy nut and you get nothing, like you can't do that. Like this child needs something, right? So some things you just can't randomize. And that is okay. We keep trying to build an evidence, and we talked about cross-sectional. Now we're going to talk about these guys. And in the hierarchy of things, as you remember, as far as talking about causality, there's a certain hierarchy, that kind of pyramid that we saw. So we're kind of looking at this middle part. We talked about cross-sectional, like we're going to try and build up into cohort studies and case control. And the more you go up on this, the more internal validity, the more that comparison gives you more evidence towards causality. Here's kind of the same idea. So let's look at that kind of top middle area. We're moving up. Let me skip that. It's a quote that says, we got to randomize, and this is important. So let's just talk about observational studies. So here we are taking people, we classify them according to whether they have an exposure or not. We observe whether they have a disease or not. And there is some time element now. For cohort and for case control, there's some element of time. Now, whether the time is going to happen in the future or whether you try to do recall and understand the past, that is going to be different situations, and we're going to work on that. And so in these more observational studies, people, we are not controlling who gets the exposure or the conditions. So it either happens naturally. For example, you have more pollution where you live than where I live, for example. This is in your environment. Or it is something that you choose and I can't choose for you. Okay. So there are different kinds. We've got this longitudinal perspective cohort. We have the retrospective cohort. We have the case control. The idea of the cohort study is that we have people who might be exposed but might not be exposed, but we follow them over time. And we see if they develop a disease that we are interested in. So we have an idea. And largely I'm describing a perspective cohort, and I'm going to do it in much more detail. But the idea is suppose I'm interested in some disease that people don't have yet, and I want to see what happens. Maybe it's mortality, right? I have actually a good example I could maybe prepare for you tomorrow. Say that I'm looking at people who get diagnosed with HIV. And then, and I'll share this example. We did this in Tanzania. So I have people who are diagnosed with HIV. They begin antiretroviral treatment. And suppose my exposure is depression. Depression is extremely common in people with HIV for obvious reasons, right? So I get people, they're all diagnosed, but then I screen them for depression. So I can identify those who have symptoms of depression and ones that have better mental health, right? And now they will start taking their medication, and I will follow them over time. And I can look at many outcomes. I can look at mortality, right? For example, do people who have better mental health, do they have a longer life? Or is the risk of mortality greater with people who have depression? Actually, it often is greater with people who have depression. You can look at disease progression. You can look at CD4 counts. Whatever the outcome you are interested in, you start with right now in the beginning, everybody. So for example, if it's mortality, everybody is alive, obviously. You have people, the event, which is mortality, hasn't happened yet. So you take someone with no disease or no outcome, but you measure the exposure. Do they have depression or are they no depression? And then you follow over time and you see when mortality is occurring. And you see in the exposed group, exposure is now depression. Do you have a mortality rate? Unexposed people who have good mental health, they have a mortality rate. You can compare those two and see if you have a higher mortality rate in one group. That suggests that the depression is affecting mortality. Make sense? Yeah. So that's cohort. This kind of case control, and that's kind of a prospective, right? I start with this, but everybody is living, there's no mortality yet. I'm going to see what happens in the future. I'm not going to try and control the situation. So the exposure is known, but there are no events, no disease, or no mortality yet. Case control, it's different. I don't start with the exposure. I start with the actual disease. So maybe I'm looking at a cancer. I start today and I say, I want some people who have some type of cancer I'm interested in. Those are my cases. These people have cancer, and then I need another group who has no cancer. And I want them to be somehow similar. I want to be able to reasonably compare these two groups. And then I say, well, what is your history? If it's lung cancer, did you ever smoke? if you smoke, when did you start smoking? How long did you smoke? How many cigarettes in one day did you smoke? Like that, I can get your history. So I'm looking retrospectively at something. And the value here is that you know, some diseases take a very long time, right? If I want to do a prospective study of lung cancer, I might need many, many years in order to see any kind of result, right? But if I start with people who already have the disease and I go backwards, and I mean, I can find these people. The hard part is, like Ketmani was saying, like she's looking for uncontrolled and controlled diabetes. The hardest part is finding the people and then being able to have a reasonable comparison and then being able to have a good recall of their history, right? So there, it is challenging, but it's a little bit easier than waiting for someone to develop diabetes. It might happen in 1 year, it might happen in 10 years. Like, you know, you might be working for a long time. Yeah.
I have questions.
Uh-huh.
For the book of perspective.
Mm.
How we know that how long that we will do the study for the, for example, if coma study, we like measure smoke and disease, but how long?
Mm-hmm.
How we
For a perspective,
for perspective and for perspective as well.
mm-hmm.
We do backward, but how long for the backward that we will?
You have to have some knowledge of the biology and the kind of social, depending on whether it's a biological thing or whether it's something more social, right? Like you have, yeah, you have to know a little bit about like, so do you have, so for example, if I want to do a prospective study of cancer, I should have some data in my population about incidence of this type of cancer. So if the incidence is very, very small, and you say, I want a prospective study, then you better be ready for like 10 years of work, right? But if the incidence is much more common, right? Like if I'm taking a cohort of pregnant women and I'm following babies until you see stunting, like a diagnosis of stunting. Okay, I mean, unfortunately, some stunting is rather common. So within 1-2 years, you might see that outcome, right? So you know the biology of something, right? You know that stunting, a lot of stunting will happen in the first 1,000 days, right? So that tells you some time frame. You know, if you have data from your population on incidence of cancer or incidence of diabetes, you have an idea of how much time. So there's the biology, there's the population level, like data that you have. If it's something more social, like some kind of behavior change or something, then you should have some kind of theory of how it's going to work, right?
For example, if we would like to do a study on diabetes, and we know that diabetes is all occur often in the age of 65, for example, or 40. So if we would like to do a study adolescents, that we follow them till that age.
Yeah, you will be ready to retire by the time those children are growing up, right? So well, maybe you have a long time to retire, but you know, yeah, you have to think. If that is your first study in your research, like it's not gonna go well, right? Like you have to, yes, the cost and the time to get any kind of result, right? It's going to be hard. Even the retrospective, like you have to have some either knowledge of the biology or of the social situation. So like, for example, if I'm looking at some type of cancer again, and I have people who have cancer, people who don't have cancer. I mean, do I need to know their exposure 1 year ago? Like 5 years ago? Does it matter if they have a childhood exposure? I mean, maybe you don't need to go so far back, right? But maybe you do. Like, it really depends on the biology of this cancer. You know, a lot of these things might be lifetime exposure, or it might be cumulative, or it might be very recent, right? And it's a tricky question because we don't always know the biology, right? Like, so if you're looking at stunting and you look at maternal, nutritional status in a retrospective way, I mean, there's evidence that preconception matters. So Maybe you go back as preconception. What about her adolescent time? Right? What about childhood exposure? What about childhood stunting? You don't really know, but you have to, that's how you have to make the decision about that. It's not clear, but you know, some things you have to, so you have to have the plan and you have to justify. One of the biggest mistakes, like I think, is one, there's an exposure, you're interested in it. Actually, there's a lot of things that can go wrong in these kinds of studies. The exposure should be very well defined. What is this exposure and how is it measured? And you don't want to change, you know, like maybe 2 years from now, a new method comes and there's a better biomarker for that and you want to use the new one. You can't, because then how do you compare, right? If you change the protocol after 2 years, right? So you have to clearly define an exposure and the method of measurement, clearly define the outcome and its method of measurement, and you can't change it. And then you also, if you think there is confounders, which in health and nutrition, there is always confounders, like hundreds of confounders, right? If you think, you know, you want to collect that data from the beginning. So you really have to think in the beginning of something. So for example, if you think socioeconomic status matters, right? For most health outcomes, it does matter. So then you have to have that data from the beginning, and it has to be measured in a certain way, and then you can't change it later, right? Like if you're measuring it according to some wealth quintile, and then you decide to use income and KIP, and then next year you change, you won't be able to compare back in time. So all the confounders that you think are important, what will always happen in these kinds of longitudinal studies is that you get to the end of something and you're like, wow, wouldn't it have been interesting if I just measured this thing? Like we all do that. We all, like, you get to the end and you're like, I really wish I measured food insecurity. Why didn't I do that? But it's too late, right? So planning all these things is all very important. So, yeah.
Okay. Case control study and maybe retrospective cohort study or prospective study can go together. For example, I have the one topic about low birth weight in Central Hospital in Vietnam. For example, the topic, and I review the case about around 10% or 20% is low birth weight in Central Hospital. But for my question about, we select the case because you said in study this is all, we just select all and we follow for 1 year how many cases and pure something like this.
So your exposure is low birth weight, or is that the outcome?
Outcome, low birth weight.
Outcome. And what is the exposure that you're interested
Like a minus, beta, or economic, or behavior, or doubts.
So it really affects what your question is, right? Like, so if you're waiting until a child is born and you get the low birth weight children and the healthy weight children, and then you're looking at maternal exposures through pregnancy or before pregnancy, then it's retrospective. It's a case control, it's retrospective. The future would be like if you enroll pregnant women, or even you enroll women of reproductive age and you wait until pregnancy and then you wait until delivery. That would be prospective. So I enroll pregnant women that come for their first antenatal care visit, and then I watch, and then I see, like, the baby, what is the birth weight? Is it low or is it normal? That would be prospective, where the outcome is low birth weight.
Yes, we can separate things together.
I mean, if you have different kinds of outcomes, but you know, the way you sample is very different, right? Because if I do perspective and I just take pregnant women and I wait until delivery, then the low birth weight, you might have, you said 20%, which is a lot. Like you have 20%, yeah. So there'll be 20% and 80%, right? But if you do case control, probably you'll pick 50% low birth weight and 50% normal, and you look back in time, so then you have similar groups and you try to compare them. Right? So that 50% is not the true like population number. It's just you have a sample and you pick half to be the low birth weight and half to be the normal. If you do perspective, you won't get 50%, you'll get 20%. Because you're just taking a nice sample of pregnant women and seeing the outcome.
Yes, one more question. Because it's when I studied, some professors said that if you would like to select the test, maybe 1 year you did the study, and you select about test global weight only, and you ask interview something and you ask the back. It's
The history.
yeah. But I would like to discuss with you like can we not select about the case, but we interview all the women come to a hospital for 1 year, and then we can this like a define case of your company.
I mean, you're kind of waiting for the it's sort of perspective.
Yeah,
You're waiting for cases to come.
needs to get inside in my
Yeah, but you do want to be very careful about like how you're selecting people. And there's like, I don't know, this topic has like 60 slides. So we will talk in a lot of detail about this. But like, you also need to think about like, what are you representing? You know, like, is it, the samples need to be representative of who
yes.
and what, and like, are you waiting? And as you're doing like enrollment over time, situations can change. You know, because as time goes on, you have a new public health campaign. You have food prices getting very expensive, like life is changing as well. So you want that group to be kind of similar. So, you know, there's a lot of considerations.
Because the first design or test cross-sectional study, 6 months, 1 year, and then we found the lower limit in maybe example 10%, and we would like to look back is the case and something like that.
And get their history and try to compare. That is okay, but it depends on your sample size. Right? So if it's 10% and you have, I don't know, 1,000 women, right? Then you have like 100 versus 900. So it's kind of small in the cases, right? And that's the thing about case control, is a lot of times when you have something that's kind of rare, because if you do a perspective study on cancer, you might have 1,000 people and still get like 2 cases of cancer, right? Like, and then you compare 2 to 998, like it's not gonna work, right? So case control is where it's hard to find cases. So it's a rare disease, relatively uncommon, or it takes a very long time to happen. So like diabetes, you're waiting for the adolescent to get diabetes, you can easily wait 30 years, you know, for that. So that's not going to work. So you have to do something retrospective. So it's those scenarios. If you have the choice, I mean, I would say like if you have the choice, if it's reasonable, doing something perspective makes a lot of sense. I would say aim for a perspective, unless you have a rare disease, you have a disease that takes a long time to develop. Those kind of scenarios, then, or you need to know now, like, then do a retrospective. Because a retrospective one, it has more limitations, right? In the hierarchy, it's a little bit lower on the pyramid. So do it when you have reasons, right? And if you have a chance to always go higher on something, usually it's better. Not 100% all the time, you know, but most of the time, if you can do a little bit higher, it's better. How are we doing? Okay, yes. So this is the idea of perspective or cohort study. You get people, you have your population, you pick your sample, you assess the exposure, and you watch, and you wait until the outcome. That's the idea. And then, so that's cohort studies. And then, I don't know, what do you think? Should we go for lunch or should we continue in cohort next time? Everybody wants. Are we okay? Is this good time for lunch or what? It's 12 o'clock.
I think I go a little bit more.
What's that?
Can we go a little bit more?
A little bit more? Oh, boss is saying more. Okay. Okay, yeah, we can go a few more minutes. Let's do it. Okay, cohort studies, and then we'll stop and I'll try to do some examples after lunch to get our energy going. Okay, so this is kind of just, you guys are discussing so nicely and asking questions very nicely. So I think we said some of this stuff. Perspective is in the future. So you have different levels of exposure, and you follow until you see the outcome. So there should be you define what the outcome is, and there should be no outcome in this perspective cohort yet. It will come, but not yet. And then retrospective, there are already exposures and outcomes, and then you need this recall. So again, this is kind of where the hierarchy is. Perspective is a little bit more rigorous than retrospective. So you use things depending on the type of disease you're looking at, the type of outcome, the type of time you have, a bunch of different factors. This is kind of where things are. So yes, so this is kind of saying the same thing. Okay, so just kind of some few definitions. So cohort just means a group of people. That's what that word means. So it can be like a cohort that's defined for your study or just kind of in a general population. It's a group that shares something. Like you guys, so for example, we use the word cohort in the university where it's like the new batch of students every year that we get, the kind of like a group of, they're going through the same experience together. So we call them cohort. So they don't have the outcome yet. So you can kind of say that they're kind of healthy. And then you are not controlling the exposure. Their own behavior is controlling the exposure, or the environment is making the exposure. So there's no randomization, nothing like that. You're trying to make a causal connection. And then you're looking for you're looking for that disease or that outcome to happen. So sometimes you're looking at incidents. So when I talked to Kate this morning, she was very sad to not come today. And she said she promised you this whole discussion of prevalence versus incidence. And I said, okay, we can wait until, you come and we can share that. But you can look at kind of different things. So for example, let's use this just HIV example, and I'll share something. So here's time, right? And time is happening. So you start here, and then you find out you have HIV diagnosis. You start ART, the antiretroviral treatment, and then therapy, and you assess the exposure, and that's, in this case, assess depression. And so you have people who are here, and you follow them from their diagnosis onward. And then here, so someone might have mortality, right? This one might go here until death. This one might have very long, off the scale, something like that, right? So there are different things you can do. You can look at maybe this is 1 year. So you have different kinds of statistics that you can get from this. So maybe you can look at mortality in 1 year. So in this example, you have 0 mortality. This one is later, this one is later, this one is very late, right? So you can look at mortality in 1 year. You can look at the number of cases. Maybe you have 1 mortality here and 1 mortality here. Somebody else, 2 other people died. So you can look at mortality in this this amount of time. So you can look incidence in a certain amount of time. You can pick one point of time and say, how many so far at this time? Maybe you look at 1 year survival and you look at 5 years survival, something like that. Or you can look at the time until the event is happening. So this person lives, 24 months, this one lives 18 months, so there might be some number you want to get out of this. So you might have different objectives, right? And it really depends on your outcome, right? So if this was HIV now with good management, you can have a very long life with HIV, right? So maybe you just want to look at this, but if this is people who do chemotherapy, and then you want to look at survival after chemotherapy, but you might still have mortality, right? So you might look at 1 year survival rates, and like mortality might happen everywhere, but maybe the thing you want to improve is how long, right? Maybe the median survival time, if you have an intervention or a medication that can improve the median time of survival from 1 year to 3 years, okay, that can be useful, right? You still have mortality, same rates of death, but you extend the lifetime. So that can be nice. That could be that. So there's different sorts of outcomes that you might be interested in and different ways to measure. Does that make sense? Depending on your preference. So you can have the same mortality rate, for example, but if with the exposure, maybe everyone is dying after 6 months, and with no exposure, everyone is dying after 2 years. It's better to be no exposure, right? So, yeah.
So if someone die before the disease occurs, we don't that information out or the information or we still use that information.
That is a complicated question. So if you are looking for something like some comorbidity. So for example, with HIV, you can develop some other comorbidities, right? And there's some increased risk for certain NCDs. So maybe you're looking at diabetes or something like that. But somebody dies before they ever develop diabetes. So do you call that like loss to quality? And it might depend on the cause of death, right? And like, that is not a simple question. You can spend like a week explaining that. Because so there's a whole area of analysis called survival analysis, where people will do this kind of thing. And then you have something that's called censoring. Maybe you've seen that word if you look at it. Yeah, where it's basically like you lose somebody before you can see the event. So you can lose them because they died. Before they develop diabetes, but you can also lose them because they migrated. Yeah, or they withdraw, or they don't want to participate, or like there's many reasons. So it's not only because of something negative.
Lao study the pull-up student in the 3 periods of time during 2 years. Baseline, line, and some children drop out a little bit, migrate to somewhere, either baseline or something baseline and something in line. Do we still use the information or?
Obviously, if you lose them and you have no data, there's some. In general, it's a good principle in studies to use all the data you have. So if you have some information up to this point, and then this is actually migration. Right?
Migration or withdrawal or die.
Yeah, migration, or the parents say they don't want to participate, any kind of thing. But, maybe you took CD4 here, and here. You still should, I would say, use this data. And then what you don't have, obviously, you can't use. But use what you have. And sometimes, especially for RCT, they call that intention to treat. Yeah, you just use what you have. You don't, because what you can see is like, okay, this person is migrated. Let me just, I'll just drop him completely. But then that can create bias, right? Because who are migrating? Like maybe they go for a job because they don't have opportunity here. You know, like, so you can create bias when you just erase people. So use what data you have and then, you know, really analyze, like, is there anything special? So for example, if you have migration or you have people who withdraw from a study, like you know their kind of baseline characteristics, right? You have some data. You can look at the people you lost and the people who stay in your study and just look for differences, right? Is it that women are more likely to drop? Is it that people with low income are more likely to drop? Is it that the rich people are more likely to drop? You know, you can look for that. And it doesn't prove 100% anything. But if you find that there isn't any like systematic difference, it's a little bit stronger. You can say like, okay, I had HIV is a great example because you will lose people. Like some of them, you know, it's because of death. But then other people, you know, there's stigma and they don't want to be associated and they try to hide their disease status, so they don't want to come to clinic. Or they live in a difficult situation or they don't have money or, you know, there's like a million reasons. So these kind of studies, you can have a lot of loss of participants. But if you can see like the ones who were lost were kind of similar in the demographic profile to the ones who remain. So we don't think it's introducing too much bias. You can kind of say, if they are different, and you find like, okay, the ones with very severe disease status are more likely to stay because they're hopeful of a, you know, like of some benefit of being in your study. And the ones who drop are the ones who are very healthy, like they feel they don't need your study and they don't have time and, you know, they're not as motivated because they feel good. So then you say like, look, my results kind of apply to a more sick population. Like they're all HIV, but it's maybe the more sick ones who are remaining in my study. So my external validity or that I can generalize to a little bit more sick population. I'm not sure about the more healthy, well-managed cases. So that's a discussion. It's more than a discussion, right? Because your job is not just to make a report. You want to make a recommendation. So can your recommendations apply to the people who drop out? Maybe, maybe not. Yeah. Okay. So we're trying to talk about causality. We are looking at incidence of diseases. Okay. So here, cohort studies going up from already went. He's already gone. Okay. He misses. Cohort studies can be called panel studies, longitudinal studies, prospective observational studies. Lots of words, all in one language, probably different languages and more words. So the point and a lot of the differences, so this can cause confusion, but a lot of these different terms come from different disciplines. So again, the panel studies, economists like that term. Epidemiology, people like cohort. Statistician, like me, I like longitudinal, but that, you know, you might have a different word. So here we are. Here's kind of the situation. And this is also worthwhile for every study. There's some, you know, we kind of talked about this a lot. So we didn't really talk about these boxes. This is true for every study. So we talked about this when we talked about RCT. You have a population. There are some people, it's not every person, right? Like you might be looking at a subset. So for example, in that malaria study I shared with you, we looked at first and second pregnancy. We looked at HIV negative. So we excluded certain people. Some people were not eligible, and that changes what your population truly is. And then even among the eligible, some people don't want to be in your study, right? And sometimes it's usually not random. Like if you ask me to be in a study and I don't want to, I don't want for a reason, right? So this not participation can also be bias, right? Like maybe I'm too busy or I have lots of children and I don't have time. I have to take care of my kids. Like, so that will mean that then maybe your participants have fewer children or they have an easy job and have more free time, you know, so thinking about the bias that's introduced that's true for every study. Okay, so prospective design, we look at smokers and non-smokers, we look for cancer in both groups. The retrospective is going backwards in time. So this is a bit of a complicated thing. Let's see if we can make sense of this. So we're starting here with so perspective. Let me go back. We start here, assess smoking, wait perhaps for a long time to see if any disease is developing. Here we're starting with the disease, and then we're asking, did they expose to those risk factors? And we want to include exposures. We want to hypothesize exposures. We want to include confounders. We are going to be excluding some people in the whole process, right? And another thing, and I assume it comes in the next slides, when you're doing this retrospective thing, you have to like get records from people, right? So you have two options. One is if you have a nice medical record, then you can go through medical records. If you don't, you rely on the recall of the participant. And the recall of the participant requires that they can truly remember and remember accurately, and that they're willing to tell you correctly, right? I mean, if you ask something very sensitive, you know, maybe they don't share, or they don't give you exactly the right thing. And there are certain times where it's hard to remember if you ask for childhood exposures or something that is long ago. If you ask me about last year, it's difficult. If you ask me about last month, it's not bad, right? But depending on the disease and the exposure, you might need to go back a long time. Even medical records can be incomplete, or some people has a record and some people don't have medical record. Those things are probably not random, right? Like someone who is migrating to the capital city probably doesn't have the medical record, but someone who lived here since childhood probably has maybe something, you know, so that can also create bias. Okay, how are we doing? How are you doing? Let me see, actually, any more? Okay, we do have some more. Do you want to take a break now? Yeah, up to me. Oh, I can keep going. Yeah.
We want you to take a break.
Okay. You're like, we're tired of you. Unfortunately, you don't get cake. Okay. Yeah, I guess lunch is okay. And then we come back at what time? We is not the boss. 1 o'clock? Okay, 1 o'clock. All right. Okay, so I'm going to, are we ready? Got it, ready to go? So we're going to do more examples, and I'm going to do a little bit of data. And I just wanted to ask you, because it's a bigger group, the people who have done earlier work with the project, they kind of had some exposure to Stata, but then others of you, some of you are using Stata, some of you are not using Stata. And I just wonder, like, in general, when you have data, how do you keep your data? Do you use Excel? Do you use SPSS or Access or Stata? What do you do?
They'll
Excel.
for the graph, but like not analyze the relationship. In fact,
As what?
AP data to the data all, and then export any statistic software. Maybe in the AP data to be analyze like easier.
I think does anyone use SPSS? You use SPSS. I think you use, yeah. You use? Used to use. Do you have, is it available in SPSS? Not very available, or what?
Honestly, I use the private version. but not in Mac, not in Mac.
Right, Mac is a little bit harder. Sometimes you have to have like a virtual machine or something like that.
PC.
Yeah, right. Yeah, I think this is just something to think about. So when you have a very large data set, like the thing that worries me for Excel is that it's very easy to change numbers, right? Like you just open it and if you just like, you can change a number and or delete something or, you know, like things can change. It's very easy to change things. When there are things like SPSS or Stata or some of this other kind of software, like you can prevent that. And when you're creating new variables, if you make a mistake, it's easy to kind of undo and go back to the original and start again to correct mistakes. So as far as data management, I think it's something to just think about. I struggle with it because like there's different softwares, some are easy, some are hard. Actually, none of them are hard. It's because when something is new, it takes time to learn. And it's a little bit, frustrating to learn. And like the best way to learn really is you just try something and then you're trying to do something and you Google and somebody has some code or some instructions, you try it for your case and you learn just by this practical like experience. It's very hard to take like a data course, and do that. So I think it just comes from experience. And once you have an experience, you don't like to change like what you're doing. So I use SAS, which is another software, and I've been using it for like more than 20 years. So when you say like, well, okay, but this project is liking Stata, like I'm not like it's difficult to change. So for all of us, it's kind of difficult. I think to think about, and it's very hard to think about, I think as researchers, because for us, we're always like moving so fast. There's so many projects, there's so much data, and then you have so many students who are also collecting data, and like you have to manage everything. And so to kind of improve the process is sometimes difficult, but it's worth like just taking some time and thinking long term how you want to manage data. Because in the long term, like something like Excel, it may not be the best option, but then what is the best option? Who's going to learn it? Sometimes like right now, I have a student who's very good in Stata and she will graduate maybe in 6 months. And so when she's gone, it's like, what do I do now? Because she's gone and I don't know the way. She knows more than me, honestly, for Stata. So that it's a challenge for people like us who have, students or people or employees, and then they leave and go somewhere else and you lose that and you don't know everything comfortably yourself. So how do you invest, and plan your staff, your students, so you maintain that knowledge and maintain that skill when it's not possible for you to know everything? I don't have a good, easy answer for that kind of thing. But what I can tell you is that like the data management, it is really important to kind of have systems where you keep your data like very safe, where it cannot be changed easily. For example, like if you do a study, it's such an amount of work. And you might do multiple projects with the same data. You might have students where, they're learning, they're not very careful. Like you want to keep your data very safe. Nobody changes anything, nobody deletes anything. If they make a mistake, you want to be able to fix the mistake easily. So thinking about that, like what I often do is I'll have my master data set somewhere in a folder nobody can touch, then one person is in charge. Sometimes it's me, sometimes it's like a senior student, who I have a good confidence in that they can carefully keep it. And even then I don't touch. So then I'll take a copy of that data and do my analysis, but I never touch the original. Because if something happens, then all that work, is at risk. And you want to make sure you have backup copies, things like that. So I think like figuring out the best way to do this. The other thing is to do analyses as you try to improve your research and have new methods and make it more rigorous, and you try to build a reputation, you know, in the nation, in the region, internationally, and you're aiming for that. Like you will have to do more and more complicated analyses, and Excel might have some options, but they may not have everything, right? At some point, you're trying to do odds ratios or something and relative risk, and some of those things are hard to do in Excel, but you can do it in SPSS. You can do it in Stata. You can use SAS. You can use R. R is free, but sometimes it takes some practice to learn how to use R. All of these things it's not an easy answer, but I think if you can make time to, I think also as researchers, we're very busy that we have no time to think properly. Like we try to solve the problem today that is happening today, and we're not thinking long term. So if I stop and I think long term, like what do I need to do to organize my data? You know, in the next year, I'm going to have like 5 students working on this and that and that. And then the next year will be another 5 students. Like, you know, in 5 years, you have 25 students who are all putting their hands on your, you know, like, it's a mess, right? Like, so I think the long-term planning, if you want to keep doing research, thinking in this way, I think it's necessary, but it is difficult. You need to just take time and sometimes spend more time now, and it will save you some time later. It's very hard to do the forward thinking in the sort of career that we have. So if anyone knows a solution, please tell me. But until then, I'm going to show you some methods, and I'm going to try and use Stata. And I was literally like, and again, I use a different software. I like it very much. I'm not a Stata person. My students are, so I'm learning also. And I appreciate what Stata is doing, but I'm still learning. Okay. So what I want to do is introduce a few things. I want you, like we talked about odds ratios and all of that. We're going to start logistic regression hopefully tomorrow, and that you need to know odds ratios. So today or tonight, when you're just go back and try to like look at those slides, and I'll send to we, and we will send to all of you. Just try to kind of get the idea and just keep it in your head. And then tomorrow we will build, and we'll just keep building up that way. Okay. But I want to go back to this one, and I want to do a little bit more kind of just refreshing of what Roger did last week. So this was the paper from yesterday, and this was an RCT, but we were treating it like a prospective cohort. So we were looking not at the intervention, but at some other kinds of variables. And specifically, we were looking at the maternal hemoglobin status before the conception, before pregnancy, and how that's affecting the baby. So, so this is just review. I just copied from last time, the same things. So we had different kinds of outcomes, and we spent a lot of time on this. And I want to make just one correction. Not correction, but I said something that then I thought about it, and I said maybe I need to do better. We looked at just this one example. Let me put it like this, and I can make it big so you guys can see properly. Oops. We just talked about this 0.06 right here. We said, let's look at maternal hemoglobin, how it's predicting child hemoglobin. This is a regression. And I said that this number here, this estimate was 0.06. And I said it's statistically significant. It's a little bit borderline. I said it was a small effect, but actually I want to revise the idea that it's a smaller effect. So you have your Y, which is hemoglobin of the child. And this is a true number, right? This is some number you measure in grams per deciliter. And then you have an intercept plus a slope plus x plus epsilon. And this x is hemoglobin of mother. And again, this is a real number. This is not like some sort of theoretical thing. This is your model. And this 0.06 that is here, right here, that we're saying is significant, that is your estimate of the slope, right? So that is your estimate of this. What you're saying is this is 0.06. Okay? Now, let me go back to presentation mode. So, okay. So if that is what we're coming up with, then just in that example, if the hemoglobin of the mother before conception goes up by 1 gram per deciliter, how does the hemoglobin of the child change? Mother HB goes up by 1 gram per deciliter. Then what happens to child HB? It goes up, yeah. Yeah, it goes up by that slope, 6 grams per deciliter, which is relatively small, right? But it is at a population. So my mistake, I think was kind of a mistake. Yesterday I tried to say, okay, it's very small, but at a population level, it may not be that small, right? If it goes up by 1, so per se mother prior to before conception, it was 10 grams per deciliter, so she's anemic, and it went to 11, so she's kind of borderline. So going from 10 to 11, then a child's whatever the baby's value is, it will go up by 0.06. But what if she goes up by 2 units? So if mother, the same one, increased by 2 grams per deciliter, then child is going to go up as well. By how much? 0.12. It's this number times the increase. 0.06 times 2, this is grams per deciliter. Okay, so it's 0.06, that's the slope. Slope times the increase, which is 2. So you get 0.12. So if the mother went from 10 grams per deciliter to 12, then you're saying, no, okay, now the child is going up by 0.12. So if the mother went up 3 units, then the child goes up by 0.18. So after a while, you can see like, okay, this might, it's not a lot, but it's something, right? And at a population level, it might actually be very meaningful. So it's worth knowing. There is no absolute rule. It's just a judgment, right? Like what is an important change? But what this is telling you is that the maternal status does matter even before pregnancy, right? You're talking about 40 weeks before anything happens. Like that status of the mother is still important after 3 months, after 6 months, and even 12 and 24 months. That is still making a difference for the child. And they do this even after they adjust for these other things. So they take into account many other factors that are contributing to a child's hemoglobin. Even then, this effect is continuing, right? Like this is 0.08, this is 0.07. Like it's small, but it's still significant. And it's for me, rather surprising, right? You might like a 2-year child and then preconception, we're talking like literally 1,000 days, right? Almost 3 years of difference, that a woman's status here can affect her baby 3 years from now. That is to me rather surprising. So I think there is like more significance there than we said. Now what they're doing here is that they do, so this was maternal hemoglobin and an actual number continuous with a continuous outcome, the child hemoglobin. Now we're doing like, what is Roger's like favorite thing, which is moving from continuous to categorical so what you're doing here is this is the X, right? This is our predictor. X here is the maternal one. And so you're going from a continuous to a nominal. Like here, it's any anemia, yes or no. It's a binary outcome. And then when you go from here to here, you're doing the maternal as a continuous, the maternal as the binary. And now you're doing the outcome, the Y, as a binary as well. So you're basically doing all combinations. And what this is here, when we do child anemia, when we change this to something binary, this model actually changes. So we want this to be, so child anemia. So that's a yes or a no, right? Either it has anemia or doesn't have anemia, it's a yes or no. And so once we get into this, what we have to do is change our model in a way that we'll talk about tomorrow and do a logistic regression. And when we do a logistic regression, we come up with odds ratios. So you'll see here, these numbers all down here, these are not in the unit of gram per deciliter. These are in terms of odds ratios. So if you look at here, this footnote, values are OR, 95% confidence interval, and they have star for a different p-value. And so we'll talk about all of this later, and do some examples of this later. So I just wanted to introduce the idea. So one, to say like, okay, the quantity of the effect is really open to interpretation. Like I might have said, okay, it's not very much, but you might say, no, in a population, I think this is an important amount. We need to consider this. So there's no rules. There's only a few different opinions. And the other thing is that if we treat both X and Y as either continuous or as kind of binary or categorical, our analysis is changing, and we're going to start doing odds ratios very soon. So you can go back if you look at that paper again, now that you've seen odds ratios, try to understand what they are. Remember, with odds ratios, we're always comparing them to 1. So if the number is less than 1, then it means that the odds now of anemia is less. And if it's more than 1, it means the odds of anemia are more. So, for example, let's look here. So if the woman has any anemia, this is significant. The odds of the child having anemia increases by 37%. So if the mother's anemic, you're more likely to see the child anemic, which makes sense, right? And that's true at 3 months. It's not significant at 6 months. So in the young child, but not in the older child. And so that's kind of how you can interpret. This is actually very interesting. So here, the mother having anemia before conception increases the odds of anemia at 24 months by 68%. Which is actually quite surprising. That's a lot. Odds can vary a lot, but 68%, that sounds like a lot, So it's kind of worth thinking about. So go back and look through the paper. So now that you've seen odds, when you're just kind of reflecting on this, remember what odds are, and then go back and look at this paper again, and then think about the interpretation, and then we'll keep working on this example. Okay, I think I have this here, but I don't think we need to do this again. Okay. So we've done this before, so I'll move on. Any questions actually before I jump into other stuff? It's a lot of discussion. Yeah. Tell me, are you okay? Yes. You guys. Okay. Okay, I'm going to do some examples from the mix data from 2017. And I'm going to use, and I think especially Roger was using some of this mixed data to show data and all of that. So I just wanted to say something because we have been debating this. So I'm not using all the mixed data. I'm using like a small portion. It's like a 10% sample of the sample of mix. So it's about 1,181 observations only. So it's like a small piece. And I just want to mention, let me make this display better for me. We're using the mixed data to just illustrate the methods, but the mixed data are not a simple random sample, right? First you take the province, you stratify by the province. Inside the province, you're selecting villages, and then you select, households inside the selected villages, right? So you have stratification by province, and then you have this cluster sampling, first village, and then the household. And so that structure means that you need to account for all of these things when you do your analysis. But that makes life a bit complicated, so I'm not going to do it here, and Roger was not doing it here. But if you are truly, truly interested in mixed data and you're analyzing mixed data, like, you need to account for those. So I'm going to ignore them, but please realize that like what we're doing, it's not 100% proper, okay? So this is only just to show you the method and to show you some data and to show a little bit of data. And then we can share that, but like if you want to do a real analysis of mix, that's a whole other discussion. We can talk about how to include the strata, how to include the cluster sampling. It's not that hard, but you just have to do it. So we can discuss that outside the workshop, because that's a whole other, actually we could do a whole class, like a whole module on multi-stage sampling and multi-stage surveys. That's what you call, like when you have, the strata and then you have the village, like there's different stages, different levels. So some people call that multi-stage. Sometimes they call it multi-level. Sometimes they call it hierarchical. So again, there are many words, but the same idea that it's not like just simple random sample. Okay, so that is sort of like disclaimer or something. Okay, so let me, so I started looking at so I am not a Stata user, so I was just starting fresh on this data. So I'm going to just open the data and take a look and just tell you what process I used, and then just go through some examples. And so all of this is it's mostly a review of what Roger did, but I'm going to do a few new things that are going to help us build towards multivariable models, which is where we want to end up. We want to get into multivariable models a little bit more, And we want to do the logistic regression a little bit, and that's kind of the goal for this week. So let's get started. So I had some data, and the data are here, and the format for Stata is this .dta. So this was already like very nice, and I opened it, and my Stata is looking like that. So whenever I work in a new data set, like you just want to get to know your data very, very well. Like you want to know everything about it, about the whole data set, about specific variables. Like ultimately you're going to make claims and you are responsible for what you're going to tell people. So like, I just want to like, explore a lot. The more you explore, like Roger talked about visualization and stuff, like some of that stuff is just for your benefit to really understand what is happening in your data. So you can really understand and understand what's happening and then communicate it to others, make recommendations in a very, like, with confidence that you feel like you're saying the right thing. So when I have this data, the first thing I do, I guess, with the new data set is just kind of look at it. So I think you can come here. There's this data editor that's in a browsing mode. You can't change anything. You can just open it. And so you can kind of see you have so many variables. Some variables, there's a lot of missing. So, I have to look in the code book to see exactly what are these ones that have so much missing. Some of them have words. Some of them are numerical. There's a lot of variables. You can see them here. And that has a lot of information. I usually look at something like this. The first thing I check is like, okay, how many observations and how many variables? Because you have your data in some format and it's coming into a software and anything can go wrong, right? Maybe the format's not right and then the data gets, messy and something goes wrong. So I just make sure, okay, I was expecting 1,181 observations. I see it, and I see 443 variables. This is my expectation. If it's not, if you're like, wait, I'm missing like 2 children or something like that, then you got to go find out what happened, right? There's also a command to do this, which I think is, let me see, I wrote it down in the slides, and you'll get these slides. So take a look, check the number of observations and variables. There's something called describe. So you just type describe, and you get so much because there's so many variables. So it tells you observations 1181, variables 443, and then it goes through all the variables in order. So HH1 is the cluster number, HH2 is the household number, here's the language of the questionnaire, like there's just lots of variables. And the variables are here too, so you can kind of check. So if I want child sex, then HL4 is child sex. So you can, this is like a search function. So that's also nice. So just get to know, get comfortable. And then for fun, for our exploration, let's look for height for age, Z-score, right? So this is a standardized score of the child height. These are children under the age of 5. And the Z-score, if my sample is full of perfectly healthy children with no malnutrition, the Z-score, the mean should be 0. And then usually it's plus or minus 3, maybe 4, like depending on your sample size. That's the kind of number. But because so many of our communities have stunting, then usually the numbers are a little bit negative, right? So height for age. So what do? I go here and I'm just going to search HAZ. And there are 3 variables here. So, and it's very small. So I think you'll get slides and some of it, I just put it in the copy and paste the slides so it's bigger. But there's HAZ, there's 3 variables. One is using this NCHS. The other one is WHO. And then there's a flag for WHO. So the WHO is kind of the international standard for growth. So the NCHS is an American growth standard and it's a little bit older. So I would say we want the second one. We want the WHO. And the WHO comes with flags for HAs, for any anthropometry. Then their flags are just indicating if the value is very extreme. So if it's extreme, maybe there's some mistake in the data. And so there's some standard flags for HAZ, for the WHO standards. If it's greater than 6 or it's less than -6, then it would be flagged, and they kind of recommend you don't include that in an analysis because there can be a mistake. Because a lot of our populations are stunted and they're kind of more negative anyway, you're not likely to see +6, even like +4, like, you know, when everybody else is stunted and you see some child who is like so tall, probably maybe that's a data entry error, measurement error, something, maybe they got the age wrong. So the child looks too tall for that age. Like, I would be skeptical for that. So WHO standards, these are usually flagged and often excluded from the analysis. So let me try, and I'm not used to doing, you know what, that's okay. Let me do it slowly. So I want to just get to know. So whenever you have a new data set, and HAZ is a continuous variable, so you might want to look at things like mean, standard deviation, things like that. So this command called summarize, and then the variable is HAZ2. And this was something I did not know until yesterday. So you can write that with big letters or like uppercase or lowercase. And Stata is very specific. If it's uppercase, it must be uppercase. If it's lowercase, like, it has to be lowercase. So you have to like write it exactly the way it is. So if I wrote it small letters, HAZ2, it'll be like, we don't have that. But if I write summarize big HAZ2, then it's happy. So it's it's kind of picky. You just have to make it happy. So I look at this, the numbers are very small. Oh, that is unreadable. I'm sorry. And I don't know how to make it bigger. So let me see. Actually, yes, I do. I do know how to make it bigger. I'm going to do the easy way. Okay, is that better? You can see the numbers now? Yeah, good. Okay. By the way, these kind of softwares, like, they make these tables and you can always take the output and kind of cut and paste and whatever. But when you cut and paste normally into like a Word document, okay, that's not good. The original one was in like Calibri or some kind of font where nothing is lining up properly, right? Like it didn't look right. Actually, I can just undo and show you. See, like the things are not lining up exactly right. So I change it to this Career New. Career New has like every letter is the same size. So everything lines up very nicely. This is a little bit too big, so I reduced the size. And now you can read it very nice. So it's just a little trick to make it visual, to see it easily. So HAZ, I have 11868 observations. So already you know there's some missing value, right? Because the total data set had 1181, right? So a few children are missing this number. And then I have a mean. I have an enormous standard deviation. So in a healthy population where there is no stunting, no whatever, the mean should be 0. The standard deviation should be 1. Now, when we have stunting, the mean will be more negative. Standard deviation can vary. But it should not be 15. 15 is crazy. So what's the problem? The problem is this, there are some values that are 999. This min of negative 5.8, it's very stunted. It's possible in some population, you know, it can happen. It's not very common, but it can happen. But clearly this is a problem, right? Like there's something wrong in my data. So what do I do now? Let me try to look at it in a little more detail. And to do that, I just add a comma and I say detail, and it gives me more detail. So let me just make that bigger. Where's my Word document? So this, when I do this, it's going to give me number of observations. It has the mean, the standard deviation. It's giving me those percentiles. So those are percentiles. It gives me other statistics. So the mean looks familiar, standard deviations, the observations looks familiar, and so on. Here's the percentiles. Which one's the median? By the way. This number, right? Right now, that's the median. And notice the median and the mean are very different. Like there's something wrong here because again, we have some crazy numbers here. So just let's explore even more. So like, let's try a histogram. And now there are many, like with every software, there's like many options. You can make the histogram, like, you know, how big the bars are and the color and you can do fancy stuff. I'm not doing any fancy stuff. I'm just exploring. And here's the histogram. So clearly most are here and there's something weird here, right? So all of these things, now what I'm doing here are things that I would do by myself. I would never like show my boss or show the donor, like this kind of stuff. You're never going to show that, but you need to do it for yourself because you need to have confidence in your data. So there are things, and now I'm going to do something that I would not show anybody, which is this. I will do, oops, not that one. I'm going to do a tab for this HAZ. Tab is for categorical variables. It is not for numbers. But I do it all the time for numbers. And I don't show anybody because they will think I don't understand statistics. But the reason why is I just want to see what these numbers look like. So you can see it's crazy and unnecessary. Actually, you can't see because it's too small. Let me copy and paste again into the Word document, make it bigger. Oh God, it's very big. Really? All right, guys, you have to wait. Good enough. Okay. Okay. So this is what the tab looks like. And again, this is nonsense, like don't print it out, but it's, for me, I find this very helpful, right? So I can see the lowest value, it's 5.86, negative 586. It's okay, it's within the kind of okay values, but not very many. But there are some children under 5. So this is the number of children who have this value, the percent of children that has this value. And this is the cumulative. So like, okay, 0.09% of children are this low. And then this one is like, it's increasing as you go along, kind of adding the percent, the previous percent and adding, so that when you get to the bottom and you see all the data, it's 100%. That's the idea. So here you just have few. You know, again, here's sort of like, okay, here's 5% of the data. the first 5% of the data, which is here, is below like it's -4 or below. Yeah. So I'm getting a feeling of how this data looks, right? Now here's -3, here's -2. Anybody who's below -2 is severe stunting, right? Or no, it's normal stunting, normal, kind of regular stunting. Below -3 is severe stunting, usually, right? So I'm getting kind of a feeling, okay, how many are below -3? Here's -3. So 15% of my data is below -3, which means 15% of my sample has severe stunting. Okay, so this is nice. I keep going. So at some point, the numbers get bigger and bigger until I get to the bottom. And obviously, these guys, and look, I have 22 children with this value. I have 5 children with this value. So there's 27 children with just bad values. Like I don't want to include them in my analysis. Now, if I follow the standard, WHO like flags, then all these others are okay because it's supposed to be from -6 to +6. Now, in reality, I would say like, okay, that's true, but this is very uncommon, right? Especially for Lao, like children are not that tall. I would go back to even these, look at the height and the age of the original data, and just, maybe if you're doing data collection yourself, maybe you have paper records, maybe you have your field notes and things like that. Like, just make sure you think this is real, because for me, I don't believe these numbers. I think these might be mistakes also. But that's my opinion. You may say like, no, I disagree. That's okay. But I'm keeping an eye. Yeah.
The number 72 and 5. Here is the orange or
Which one?
yeah, 72 and 5. 72.
Proficiency.
The last.
99.9.
Oh, these guys.
Yeah.
These are definitely wrong. Like these, no doubt. You gotta keep this. There's no way. This is just I don't know. Maybe it was
That's
missing.
possible, right?
Yeah. So these guys for sure. I just need to remove. Like, don't include them in the analysis. If I took the mean of these numbers, these guys are going to make the mean very big.
If we
Right?
move this data and then we can run again.
Yeah, which I will do. I will show you. But what I'm saying is like these guys, no question. These guys need to go. Like, it's not correct. Like, this is not. I think somebody just put 99 because it's missing and people do that kind of thing. So just these 27 children we can't use. What I'm saying is that technically everybody else we should be able to use. But if I know my population has a lot of stunting, and you tell me that HAZ is 5.9, it's possible. But I would like to check my data, right? Like I would check just to be sure. Maybe somebody wrote wrong or did data entry mistake, or anything can happen. So any variable I use in any kind of analysis, I do this. Like I look, I want to be sure that I'm very confident, I feel very comfortable with my data. And you don't need to tell, anybody that you're doing this, just do it. Like, and if you're not sure, or you see this and you want to go back to your staff and ask them about see their records, see the paper copy, do it, until you're satisfied. So, okay. So I'm going to do 2 different things. I'm going to do, oops, wrong button. I'm going to do this original summarize of the variable, and then I'm going to do a summarize if the height for age is less than 6. So all those 99 I'm going to exclude. So let me just show you. Let me make it big and I can show you the result. Oops, there's the Word document. Okay, these are two versions. So this one, I'll make it bold so you can see better. So the difference here is that I put a condition. The height for age must be less than 6. So this will omit all the 9-9. So if you compare these two, this one had 1168 observations. So again, if this were my data, I would, even with the 1168 observations, I would also ask some questions. I would say, I'm expecting 1181. Why do I have 68? I'm missing how many? Like, why? Why am I missing them? Like, go back to your records, go back to the staff, go back and students and ask them what happened to those missing ones. So that would be the question number one. Now I know there should be a difference because I know I'm supposed to lose 27. Because 27 had that 9-9. So if I put this condition, I should be 27 less, which is correct, right? If I have 6-8 and now I have 4-1, I'm missing another 27. Like notice now I was supposed to have 1181, now I have 1141. So I'm missing 40. So I keep that in mind too, because is there bias, you know, all that questions. Notice how the mean has changed. When I have the 9-9, the mean was more than 0, right? It looks like even there's not that much stunting on average. Once I take out the bad values, the mean is negative 1.5, which is actually more, I know there's stunting in the population. I expected the mean to be negative, right? And look at the standard deviation. When you put 9-9, the standard deviation is 15. Now suddenly it's 1.5. And 1.5 is more normal. Like I was expecting, if it's no stunting, everything is very healthy, the standard deviation would be 1. Here it's 1.5 because we know there's some people who are stunted, some people are not. 1.5 is okay. 15 is not okay. Like I knew that was wrong. The minimum is negative 5.8. Positive, on the positive side, the maximum is 5.9. Okay, everything is within the WHO guidelines, going from negative 6 to positive 6. So I'm much happier with this than with that. Yeah?
What the middle 6 mean?
What does what mean?
Yeah, middle 6.
Middle 6.
Yeah, to summarize the high for A, the high for A.
Oh, is this?
Yeah.
Oh, this is saying that I want, okay, summarize means make this table. HEC2, that's my variable. I say, but only use this variable if the value is from below 6.
What does it mean? 6
was the cut, like, okay, 6 was here. Oh, yeah.
In the sense of
No. You can explain?
You can lên cái là bên bộ có sự cơ có sự đẹp của bên học sinh từ tăng môn học bên hạมีค่ะของเด็กที่มีความเป็นสมาร์ทโอ้ใช่ละนี่จะเป็นผู้ชมความระวังต่อการควบคุม
honest and division.
โบค่าที่ว่าเนี่ยของแซนก็ could you explain about the variable the name of variable percentile sense
It's not a percentile, it's the values that you think are wrong.
yeah
You want to exclude.
yeah I explain that the name of variable the name of your variable
Oh, why is it called has to? That's just a variable name in the data set.
it's yes
Height for age, C-score, height for age. Yeah.
So that command is to like to do the summary of the value that we don't fix, right? Not to exclude the 9.
Fix it with set score level.
No, the value.
มันหาโอ้ก็ยังไงนะความเรื่องในของการนั่นเลยเนาะเป็นไม่ได้แต่ต้องต้นค่าสักเท่าไหร่ค่าตัวนี้กับโลกเก็บตัวมาแล้วสูงสุดถ้าเองก็ราคาจุด9สตางค์เราตอนนี้ก็หมายถึงว่าค่าที่เราต้นตัวเด็กที่
Karena itu kan super banget.
มันสูง
Karena sensor.
มันสูงเพราะมันฟ้องตัวสูงแต่พอเราของเราหาสูงเราเก็บกับตัวมาเป็นตัวก็
Ada sensor untuk form tanah, form tanah.
ไม่ว่ามัน มันสิโอเวอร์เวทแต่ที่นั้นถ้าทักที่ป้ายหรือว่าซิลิโคนโรคโซโรคสารเนี่ยยาเนี่ยนะแต่ที่มันบอกคำบอกแสดงว่ามันทำให้ติดได้ใช่ไหมมันมีการจะมาของมันเนี่ยก็ไล่แบบเป็นจัสก์เนาะแล้วก็เป็นราคาของมันตั้งแต่เราเห็นเราเป็นอะไรตั้งแต่เรื่องการแบบมาเบอร์จริงๆขนาดมันดูจำเป็นต้องใส่คำสั่งแบบกับตัว variable มันเป็นคำสั่งแต่ว่าเราใช้คำสั่งนี้เพื่อที่จะช่วยให้เราเห็นว่าค่าของมันเริ่มจากใส่หายใส่ที่เราเริ่มมาจากเราเห็นแต่นั้นลงแต่ลงปลายเพื่อนร้อนลงหนาปลายเนาะลงหนาปลายเป็นข้อหาการเก้านี่หมายถึงว่าช่วงเวลาเขาเห็นอยู่ในหันเวลาเราใส่คำสั่งมีสุดด้านมาให้เราเห็นเขาก็จะมีเราเพิ่มของมันจะเด้เนาะเด้ย้อนเนี่ยเด้ย้อนชาและเราก็เลยใช้คำสั่งว่าหารตั้งหารเก้าหารใหม่เพราะว่ามันจะเป็นเขานั่นเขาจะหาจะแก้ตัวหาเพราะหารนำเก้าเลยว่ามันก็เลยที่น้ำตาลตัวลงไปเนี่ยมันจะจังสบายแล้วมาเพราะว่าเอาจะมีหลักพูดของสองนี้ที่เราบอกว่ามันจะมีดูสังเกตอันปฏิตัวแต่เราจะบอกอะไรเราเลยใช้คำสั่งตัวนี้แทนที่เขาจะไปบล็อกเดต้าของเขาออกเขาจะบล็อก variable ของเขาก็เลยไม่ใช้คำสั่งของตัวนี้เพื่อที่จะบริบล็อกของตัวนั้นแต่ว่าเขาสามารถเชื่อได้นี่มันถึงพวกมันมาจากใครพวกมันมาจากตัวนี้แหละแม่ค่าของตัวนี้เพราะว่าเห็นค่าของตัวนี้มันหาตัว90เป็นบางเพราะฉะนั้นแล้วเขาก็เลยเอาตามโอ้โห
Thank you for that. Thank you. That's like the teaching demo already. Okay. So it's okay?
Yeah.
Okay. Okay, great. So this is just, it's like data cleaning, right? It's before you do any analysis. And I think this sort of thing, it's important because, well, let me show you. Let me close. I have too many things that's open. If I go back here, notice how much bias you're having. A mean that could have been 0.8, or it could be negative 1.5, right? Like if you don't do this kind of checking, like you can be very misled. So I think it's very important to just check this kind of data, make a graph, make a summary statistic, even do tab, even if it's like so many pages, just scroll and just be comfortable with what you have. And I think it's especially important, and you can share this with your students. This kind of stuff is so much small detail, right? Like you're not going to put this in a paper. You're not going to put it in a report. So nobody is checking you. Like you have to kind of check yourself. And in an ideal world, like for example, if you have a data manager or someone, they would notice these things. But sometimes they miss or they don't know, so if you're checking, I think it's still important. Sometimes you think other people will take care of, but you have to just double check and be sure. So I do all this kind of stuff, and I realize I need to just look for this height for age to be less than 6. So let me go to the actual example. So I'm going to do a very simple t-test example. And so let's consider just child sex, right? So I have male and female. This is this HL4. So let me just do, so when you get the slides, this one with the arrow, that's code, right? That's syntax. So let me just do tab HL4. Looks like that. Put it in the Word document so you can see properly. What's happening? Oh, okay. So male. So I have data on, now I have data on every person, right? I have 1181 observations. I have 560 female children and 621 male children. So the percentage of male is 52% versus 47% is female in my sample. Okay, so I have an idea of male and female. That's okay, right? So what do I do next? So here's my question. So here's one research question. It's a very simple one. You will go and do bigger questions, but let's keep it easy today. Are there 6 differences in height for age C-score among children under the age of 5 years in Lao PDR? That is a question, right? And we can test that. So you have girls, you have boys. These are independent samples. You can think of sex as sort of like an exposure, right? Like you don't randomize. You have girls, you have boys, they're independent samples. You can do a t-test and look and see height for age here versus here. Is there any difference? And so this is the syntax. So you have t-test, okay, height for age, that's our outcome of interest. And remember, I want to say height for age must be less than 6, because I don't want those big 9. And then what is the independent variable? It's sex. It's the sex of the child is HL4. So I want to do a t-test by this HL4. So let me just run that. Actually, did I? Oh yeah. Oh, good. I put it in the slide. So let me show you the output. Okay, so the syntax, the result, it looks like this. So what is happening? I'm doing a 2-sample t-test, equal variance. I have the male and I have the female. So I have height for age C-score. I have the mean. I have some number of observations. And now this is different, right? Because I have, some people are missing HAZ. So my numbers are not exactly as before. Right? Every child has a male or female, but not every child has HAZ. So the numbers, observations are going to be a bit smaller. But it's okay. It's not too many. This is another thing to watch out for, because in data, we always have some problem with missing data, right? Like somebody didn't answer a question in the questionnaire, or you can't read it, or the value is too strange, and so you have to omit it. And so I always, whenever I do stuff like this, I'm always checking these number of observations and just making sure. Like if there's a lot of missing data, if this had said 300, then I really am going to go ask some questions like why, what's missing, because that will definitely add some bias, right? So so anytime you have an opportunity to check sample size of things, just check it. Here's the mean for male. It's negative 1.56. Female, the mean is 1.47. There's a standard error, standard deviation, kind of similar. They make a confidence interval for this mean. These are all very interesting. Okay, fine. Here's the combined. So if I ignore male, female, all, and take every child, here's the mean for every child, standard deviation, confidence interval, and so on. Here's the difference. The difference here is comparing male to female. If I subtract the negative 1.56 from the negative 1.47, if I take the difference, the subtraction, I get negative 0.08. Yeah? Are you okay with that? This is the difference between the average difference between male and female. And so this is the average difference is very close, right? Like these numbers are not male and female. It's not very different, right? So probably I'm not going to reject this, but it gives me a confidence interval here, actually. So it actually explains the mean of the male is negative here. Well, I don't need to write, right? It's negative 1.47 minus negative 1.56 gives you negative 1.08. Yeah. And then it has a confidence interval as well. So that's the difference. And what it is doing is studying the null hypothesis is the difference is equal to 0. If the difference is equal to 0, that means those two means are equal. Yeah. So that's what it's testing. And now I have a choice. Is the alternative hypothesis, remember, Roger was saying it can be one-sided or two-sided or whatever. The kind of computer way of saying not equal is this exclamation equals is the same as not equal. So because it doesn't print out not equal very easily, they just put exclamation and equal. So that this symbol is not equal. This is difference is greater than 0. This is difference less than 0. In basically almost 99.9% of the applications, people do two-sided. Alternative hypothesis means that they will do a null hypothesis of something being equal to 0, or this mean is equal to that mean, and then the alternative is that they're not equal. So I tend to just ignore. I tend to ignore this one and ignore this one. I'm just looking at this one. What is it? This is hard. Are you guys giving up on non-psychology?
But it's true.
Let me write that. How are we doing? Are you okay? Do you guys need a break? Or is this getting to be? No, you're okay. Okay. You can't escape the null hypothesis. Okay, so let me just to explain. So null is always that. Let's say Roger, he likes Greek letters. So let's just say male. The mean of male is equal to the mean. He uses mu for mean and female, right? This is the average HAZ for male and average HAZ for female. We're saying they're equal. But if we move this to that side, actually, which way did they do it? It's male minus female, right? Male minus mu of female. Right? This is algebra. You move that to this side, this becomes 0, and this is the difference. So while we've been talking like this, Stata does this. It's the same thing, right? Yes. So that's what they're trying to do. So what is this actual estimate? Well, this number from our sample, this was what? What was the mean of male? Negative 1. What? Wait, what? Wait, did someone say 99? What? What? Minus, and this was also a negative 1 point, was it 4? 7. Okay, what is all the 9s in here?
It's like it's the overall of the number.
Oh, yes. Yeah. So we're looking at mean of male, negative 1.6, and then we subtract the mean of the female, which is negative 1.47. And so you have to be careful, minus, that becomes plus, right? So this becomes, it's still negative because this is more negative, negative 0.08, something like that. Right? Which is right here. That's that difference. What's that? Okay, so the alternative. So again, so this is the HO. So the HA, the alternative is just this HA. They give us 3 choices, but I would say just ignore those 2 on the left and right. Just take the middle. This is that diff. Did they just call it diff? Yeah, they just call it diff. This difference, mu male minus mu female, which is just the difference is not equal to 0, or if you're state that they just use as not equal. So when I do that, they do this, and then this thing, this p, this is probability, this is the p-value. So p-value is 0.764. So 0. So now what? 764. What do I do with this one? You don't.
We are yes, then I would say
You reject or don't?
don't yes.
Don't reject. You don't reject. Yeah. You don't reject. You're saying that this difference, there's no evidence to say this difference. I mean, the difference is very close to 0, right? In your sample, negative 0.08 is pretty close to 0. It's not exactly, but you know, there's no reason to doubt this, right? That the difference is 0, or the male and female on average have the same HAZ. That's what you're going to conclude. Or, okay, we're not supposed to accept the null hypothesis. There is not enough evidence to say that there's any sex difference of HAZ among children in Lao PDR. That's the proper way to say it. Fail to reject.
Fail to reject the mistake. Rồi nó phải tốt tuyệt vời.
Vậy bạn đi bài này nó đi bài đi gần một mình luôn.
Just gonna make this smaller. Okay, are we okay? Are we okay with this? Because I'm gonna do something new next. Yeah, what did
Maybe can explain a little bit about
That means
explain what?
what is if like this, that means the male and female is the same, right? Not
Yeah.
different.
Not different.
Even though the male or female they have stud, not stud.
They have low height for age. They both have low height for age, but the amount is similar. It's not different. You can't say that the boy is worse than the girl or girl is worse than the boy. Like they're comparable. Yeah.
I want to begin the side, but
I will before I send you this slide, I'll add a few words to this so that when you look back, you'll have what we wrote here. So I'll do that. Okay. Okay. Are we okay to proceed? Are you feeling comfortable about this?
Yes. Okay.
Yeah? Okay. All right. Now we're going to do something a little bit different, but it's the same kind of thing. So I want to introduce this idea of an indicator variable. So an indicator variable is something that indicates something that you're interested in. So it's kind of definition like that. So the way I usually do this indicator variable, I use a coding of 0 and 1. So I use it's a new variable and it's equal to 1 if it's something I'm interested in, and it's equal to 0 if otherwise. So I'm making something binary, right? So for example, if I'm interested in this HL4, if you look at in the data set, the way that in mixed it's handled, if you have a 1 for this variable, it indicates a male child. And then if it is equal to 2, it indicates a female child. So I'm going to just change the coding. I'm just changing the coding so that 1 stays the same, but the female, I'm going to make it into a 0. And there's a reason I'm going to do that you'll see. In general, if you have a binary variable, I personally, I like this kind of coding. So say that I'm interested in having something a variable that is just like male. You know, so when I have the variable, I know like, okay, if it is equal to 1, that's a male, that's a boy child. And then if it's 0, it must be a girl, right? You can use the same thing for like anemia and no anemia, right? So then when it's equal to 1, then this person has anemia. 0 means it doesn't have. So I'm going to create the variables like this. So when you're doing your own data, I like this 0-1 coding a lot. It has some nice little tricks that you can do. Oh my gosh, so much fruit. Thank you. So let me create this variable. And I'm actually using a trick. So gen, this function, this thing in Stata called gen means to generate a new variable. I'm going to call that new variable male. And I'm going to just do 2 minus this variable, because if I do 2 minus 1, I get 1. If I do 2 minus 2, I get 0. So it's just a little trick. If I were, you know, the boss of mix, I would have just done 0-1. But, you know, I'm not the boss. So I'm going to make my own variable like this. And it has done it. Now, anytime you make variables, a few things. I would not change the original one, right? The original one, it's the way it is. Don't try to like just change this and keep the original variable name. Because if you do any kind of mistake, like I had to think for a minute, okay, 2 minus, is it going to be correct? Like, maybe it's 2 minus 1, 1 minus, yeah. Like, what if I did the maths wrong, right? And then I ruined this variable. And then like, oh God, how do I fix it? Like, it's going to be a mess. So in general, like, make new variables with new names. You have the original. If you make any kind of mistake, you can fix it, right? We all make mistakes, even just typing, you know, you can make mistakes so easily. So use that as one principle. The other thing is when you make any kind of new variable, even if you've done it, you know, 100 times and you feel very sure, like I never feel sure about this. So I think it's always good to check. So this is how, there's many ways to check. This is what I do. I do tab, but I mentioned the old variable and the new variable. And then it looks like this. So the old variable is this one, male and female. Here is this new variable where 1 is yes, it's a male. 0 is no, it's must be female, right? So when I look at this kind of cross tab, the male has the new variable equal to 1. The old female has the new variable equal to 0. So I'm just checking myself. Did I do the code right? Did I type it correctly? If for some reason, like these numbers are not 0 or something is wrong, like then I know. And then I go back and I fix the problem. But this looks clean. Like this seems like such a small thing to do, but I do this all the time, like check, because, you know, if you make one mistake like this, and then you do so many analysis and you write a table, you write a paper, like that mistake will keep going, right? Like, and it'll change all your results and, you know, it's very disturbing. So it's better to check now and then be comfortable later. So it's just good habit. So why? Why would you do this? So let me just show you this. I'm going to do tab and summarize of the new variable. There's a small reason to do it, and then there's a bigger reason to do it. So let me show you the small reason first. Actually, you know what? Let me do tab HL4 and then do tab.
This is me.
Yep. Mhm.
Just for information, there's some mangoes up there. Some mangoes up there.
Okay.
Fresh mangoes.
Okay.
If anybody wants.
If anyone needs snack, I'll have it later. Let's see. Okay, let me show you this. Okay. People are getting snacks. Are you okay? Okay, so here's the original variable, right? You have male, you have 52% male. Okay, everybody else is female. Here's my new variable. And 0 is equal to no, it's not a male. 1 is equal to yes, it's a male. So again, you have 52% male, right? So it's another way of checking. But here's a weird thing. So when I did this 0 and 1, it's sort of like no and yes, right? 0 is equal to no, it's not a male. 1 is equal to yes. So you can use it for any kind of variable, right? If you just say 1 is yes, 0 is no, you can use it for anemia, you can use it for male, you can use it for stunted, you can, whatever you like. So it's categorical. So you should never take the mean, but I'm going to take the mean. And when I take the mean, it's 52%. So it's just, so if you do the coding like this, if you just take means of everything, you get the nice like percentage automatically. So it's a little trick, right? So that's a small reason to use this kind of coding, because you can just take a mean and it ends up being a percent. Now the standard deviation, it has no meaning because it's a categorical variable, like you can't push it too far, but this is very handy, right? Because when you have a crosstab like this, then you have to like cut and paste and whatever. It's just easier to kind of take the mean.
Then you can guess the percentage of the male by looking at the mean.
Yeah. Because I coded it as 0
0.
for not male and 1 for male. So it's like 1 is yes, 0 is no.
Here's what's not there.
Yes.
Why we do that?
Okay, well, 1 is because I like being able to take the mean and just I get the percentage very easily without having to cut and paste in this, like this is like a frequency and whatever. That's a small reason. Here's the bigger reason. And this might be the last thing that we're doing. Oh, I cut and pasted here. Okay, so actually you guys can see it here. It's already, like nicely shown here, right?
Yes,
Yeah.
it's all like this, but I saw some person tweet saying about me for category variation.
Yes.
And if possible for that occupation or pay something.
No, it's only when you do the 0-1 coding. It's only if you do 1 is yes, 0 is no.
Yes.
Yeah.
In case of yes or no, male or female.
Yeah, if you do male, female, and you take the mean, it's like male. Like there's no mean of words, right? But if it's numbers and 1 is yes and 0 is no, you can take the mean of everything. So sometimes you ask many questions of a respondent, like, have you ever smoked cigarettes? Have you ever, I don't know, done unprotected sex or something? Everything is yes, no, yes, no, yes, no. If you can just take the mean of all the variables and quickly get the percentage, and put it in your table and, life is a little bit easy. So I do that. Is it correct? No, like, do you, like, are you gonna show your boss, like, how you took the mean of a categorical variable? Even Roger, like, no, like, but it's convenient. But there's another reason for me to do this, and that is this. So you already saw this, the t-test, right? I said, according to sex, is there any difference in height for HC score? Right? I did the t-test. I tried to limit to the valid values of HAC, and I did it by the sex of the child. That was the original sex of the child. Now I'm going to do something a little bit different. I'm going to do a regression. So again, a regression must have an X that is a number. It has to be continuous. And male and female is not continuous. But 0 and 1 is a number, right? And the slope of a regression is how much Y is going to change when X goes up by 1 unit.
When female become male. When female become male.
Exactly. What is the effect of going from male to female? What is the difference between male and female? That is what we want. What is the difference between male and female? And this is going to give us that difference from a regression. And the reason I'm doing this is, if it's just a simple question, are there sex differences for height for age? Of course, I can do a t-test and I'm finished. There's no reason to do a regression. But the thing is, I'm going to add other things to this module. I'm going to add wealth index. I'm going to add maternal education. I'm going to add ethnicity or province or something. Suddenly, then there's a lot of differences I'm interested in, and having it in that kind of format makes it easy, right? Then it helps me compare. And a lot of times you're not interested in the absolute number, like what is height for age on average for male. That's not your question. Your question is really about differences, right? You want the male, what is the difference between male and female? Not what is the average for male and what is the average for female, and you tell me it's 1.56, like, okay, what, who cares? Like, the point is there a sex difference, right? That's what you're trying to get. So that's what I'm going to do. And so, again, this is building block, right? Like, you think, okay, right now, why is she making it complicated? It's going to make it simple later. So let me show you the output. So I have the output actually copied and pasted. So you've seen this one before. This is what we did before, t-test. We found a difference between male and female, negative 0.08. And we looked at the p-value, 0.37. Yeah? So remember this. This is what we've done. Let's do this regression. So regression, here's the Y. X is the male. This new variable coded as 0 and 1. And again, I want to make sure that height for age is less than 6 because I don't want those 9 9s. And then I get a regression output. I have 10148 observations. And then I have an intercept and a slope. And notice that the slope here is the difference between male and female. Because now that indicator went from 0, it's female, to 1, it's male. And I'm getting that difference from the slope. Even though that slope, sex is not continuous, it's a categorical data. But by making it 0 and 1, I can now create a slope that is actually the effect of being male compared to being female. And I get exactly the same number, and I get exactly the same p-value. Still no different. Yeah, it's the same. Statistically, if you go back to Roger's formulas and you just do all the formula and calculation, you will realize the formulas are exactly the same. Same data, same research question, same hypothesis will give you the same output.
Shall we 5 minutes?
Yes, we can take a 5-minute break while we think about that. Yeah, because what I told you basically is that a t-test can be written as a regression. That's what I did, right? I took a t-test and I wrote it like a regression. So that was the t-test, and that's the regression. I did the same thing. So the t-test and the regression are not different. Regression is actually a very flexible idea. And you think, okay, so why? Well, when you're teaching students or when you're learning yourself, like the t-test, it's simple, it's small. You have one group, you have another group, you want to compare it. That's fine. Like it's a good place to start. But as you go along and you're like, okay, well, I'm not just interested in male, female. I want to look at wealth, and I want to look at interventions, and I want to look at this and that. And you want to get more sophisticated. It's better to move into thinking about this as a regression. And if we go back here, remember this? So this is child HB, right? That was our Y. It was continuous. We did maternal HB, also continuous. It was simple, like a just straightforward regression. This one, you took the maternal, you took the X, and you made it binary. Do they have anemia or not? Yes or no? 1 or 0. So these, in this paper, what they are doing is they created an indicator for anemia. They did a regression, and this slope, it's still a slope. That is the difference. That is the difference in child HB. So, there is this much more easy. By the way, this one I wrote down on the slide, so when you get to the slide, you'll get all of this as well, just to help you remember. So what are they doing? So now they create a variable. This is, I'm going to say mother anemia equal to 1 if anemia, and then 0 if not, no anemia. That's what they did. And then they do a regression with this. So you have child HB is equal to beta 0 plus beta 1 times this thing. This is our new X. This X, which is a 0 and 1. So the interpretation of the slope was a negative 16, negative 0.16, right? The interpretation of the slope is when X goes up by 1 unit, what is the change for the Y? When X goes up by 1, you go from no anemia to anemia, which means the child HB is going to go down by 0.16 gram per deciliter. That's what they did. Yeah.
I have a question. Why is already the outcome?
Y is
Outcome,
yes.
and it already the independent origin. So because we would like to know which one should be X and Y.
Oh, that's your theory, right? Like what you think is in reality, you're looking at the mother's hemoglobin, you think that's going to affect the child. You don't think the child is going to affect the mother.
Yeah.
Right? So the child is the outcome. So that's how you decide that is Y.
And outcome should be Y.
Yes. Yeah, this is your Y. This is always Y. Child hemoglobin. Because you think that the mother will affect the child. It will never be very strange to go backwards, right? And also this was mother at conception or before conception. This is child at 3 months. So going forward in time as well. Yeah. So yes, this is still, it's very categorical, but I treat it like a number. And then using the definition of the slope, going up by 1 unit means what is the effect of anemia on my Y, my child hemoglobin, compared to knowing in the mother. This one. So we're going to do that a lot, and stated does this a lot. And so again, the interpretation of the slope is always the effect compared to some reference category. So now we're going to expand this idea to have more categories. Now we only have 2, but what if we had more? So I'm just going to introduce to you, and then maybe we stop, and then we can refresh this like tomorrow as well. So let's just look at this. Now I can go back to normal size. So let me just introduce this variable, and then we'll play around with it. But before we can really play around with it, we have to check our variable. So there's this variable called Windex5. And now we're going to do a regression with this. Where's my word? There it is. Okay. Just to get a sense. So wealth index. Have you seen this wealth index before? One, yes. Anybody else have seen this kind of wealth index before? Yeah. What does it mean?
They have like the indicator to measure this is forest, middle, they have 5 and less in the LC. They have kind of the indicators.
So trying to put some measure of wealth, and wealth is a tricky thing to measure, right? But they have a way that's usually a composite score about assets and that sort of thing. And they put them into categories. So, so you have poor, and a wealth index itself is usually a number that is calculated from many variables, but usually then they put it in categories. So here, this is, and I think that's why they call it, put a 5 at the end of the variable name, is they put it in 5 categories. So what is happening here? I just did a tab, and what is this thing? It's probably missing, but instead of calling it missing, they put 0. So actually, if you look at the coding, these are the labels, but this is like 1, 2, 3, 4, 5. And so they said, okay, 1, 2, 3, 4, 5, it's missing at 0. But that's a complete, that's wrong, right? It's not like you have 0 wealth, it's you have missing wealth. You might be the richest person in the whole sample, but you didn't give your data, and so you're missing. It doesn't, 0 means that it's even poorer than poor, right? But it's not, it's just unknown. It can be very wealthy, it can be middle wealthy, who knows? So this is also kind of a data quality problem, right? So again, I'm starting to ask about HAZ, height for age, and how it relates to wealth. And so when I ask that question, now I have to look at the wealth variable. So again, do the exact same things. We did all this work for the sex variable. Now we looked at our HAZ, we found some problems. Sex variable, it looked okay. We did some recoding, but now we're looking at wealth. So every single variable, whether it's X or Y, just check, because this is weird and this will affect your result, right? You have full data 1181, but then these 13 who have a 0, it probably should be missing. So I have some choices, I can set that to missing, create a new variable where it have the original value, but if it's 0, I make it missing, a proper missing. Or for right now, just for this example, I'm just going to eliminate them, okay? Just keep them out. So this is how it's going to look. I'm just going to do, so now I have a problem. If I'm trying to do HAZ and I have this 5 categories of Windex, remember I had to do HAC less than 6. But now I'm also going to look at Windex greater than 0 because the 0 is the bad one. So I want 1 to 5. So I had to put more conditions in. And you can combine those conditions by using this symbol for and. Okay. So what am I doing? This will be the last thing where we're talking about many that's free. Not free yet. So, what am I doing? I'm talking about HAC and wealth. Like, do I have a research question? Yes. What is my research question?
Well, index.
Yeah.
Well, index to
HAC people. HAC. Yeah. So does household wealth, right? Okay, well, English, let's see. Does HAC in children yeah. So it is hard to kind of like write it and especially write it in English, but you don't want to be like when you're talking to people or you're explaining to your students or even when you're explaining to yourself, you're not going to be like, okay, does HAC vary and like wealth quintile, like it's like confusing, right? Like this is the real question. That's what you want to know. Is HAC the same for everybody, rich and poor? Or is there some difference depending on whether you're rich or poor? My hypothesis, so what is your hypothesis? What is your hypothesis?
HAC, like children, 35.
Is what?
Starting navigation, 22.7 kilometers in total. On Avenue Lane, safe.
The one has to go 1.2 kilometers. Yeah, what is the hypothesis?
HAC, like 35 is similar in different, similar by household wealth.
So we're not doing null hypothesis yet. We're just doing what you think.
Equal.
Huh?
not change or change like by household wealth.
Is it change or not? What do you think? Is it change or not?
If we do the null hypothesis like has didn't change by.
Well, let's not do null yet. Just tell me your hypothesis. This is like Professor Carmen, and she's asking, what is your hypothesis? Yeah.
It's a variety.
Good high level index reduce has
I'm always trying to mention the population here, though.
Can you tell me how much is it within the maximum for and what HSS?
The way you know, we
Can
can
you
do
give something like country?
What
one direction.
Yeah, what type of people are there that is
You reduce,
What do you think?
you reduce the something
Yeah, but we're not doing stunting, we're doing HAC. So things
I stand up.
will
Decrease.
decrease, it decreases. The wealthier
It's
will have lower HAC or higher? Higher, yeah. Higher is better, right? In general, we say increase the
higher.
increase. On average. I'm saying on average because our hypotheses are always about means. Of course, there'll be some poor child who is very tall and some rich child who is very small. Like, you know, not individuals, but on average, we'll have average children from poorer households.
So, you know what?
Mm-hmm.
What if we, if we aim to use different statistics and we might need to change the way of the hypothesize.
Yeah.
For example, in this case, if we are doing record, that may be about one way hypothesis. And if you are doing complement, for example, there are several times we might do an ANOVA for comparing the percent of groups between groups. So the hypothesis can be two ways, right?
Yeah, and we are going to do things two ways here soon, probably tomorrow. But first of all, we're just asking a question. So when we ask a question, this is about the real world and not about our variables. We know that these are the things we measure, but we're not getting to the variable yet. When we get to null hypothesis, we'll be very specific, right? We'll say mean of HAC, and we'll talk about wealth quintile, which group of wealth it is, richest, poorest. But right now, we're just thinking about the big picture, about what's happening in the community. So does HAC allow children under the age of 5 years vary by household wealth? And what we think, what is reasonable, is that children from richer families should have better HAC. And then children from poorer families may have more deprivation, their HAC might be lower, on average. Right? So from wealthier households will have higher HAC on average compared with these children from poorer households. Is that okay? So that's your hypothesis. Maybe you're wrong. Maybe you're right. Like, you don't know. But it's nice to just lay this out in advance. Okay, now we have to get to null hypothesis. And null hypothesis, it's very correct that it is related to the statistical test you are eventually going to do.
Okay, so
Yeah.
this is the research hypothesis, right?
Yeah, this is the research. This is the research. Now we have to get to see. This is what you want to do as a scientist. Now let's make it statistical, right? First it's just a question. Now we have to make it statistical. But what is the analysis? Here's a Roger question. You have a continuous HAC, and now you have this wealth category, like this. Okay, we're going to eliminate the zero. So we have poorest, second, middle, fourth, and rich. Yeah, so what is the type of analysis where the category, so it's a categorical predictor, right? But the outcome is continuous. So we should do two sample, but we have 5. Is it a chi-square? That is a continuous HAC. ANOVA, yes. So we're doing ANOVA. That's what we're going to go through. So, okay, we know this thing is ANOVA. So what is the null hypothesis?
how you say the distribution?
I think you can just get to the point. What is the null?
But we can be like a continuous, and we should do the proof and continuous. Maybe the score of well, one time. Maybe continuous. It's very much
It can be, but it's not like continuous means if you go from 1 to 2, it's the same as going from 4 to 5. But here, like this richest might be so wealthy, you know, and the poor, you know, that first step maybe you go by a little bit, and the next one, and then the last step is like super rich. Who knows, right? Like it's not like a normal number where you can just go step by step. There can be a big jump somewhere or a small one. So look, if it weren't 5, we're gonna get. Let me just get rid of this. We're going to say we're just going to get rid of those guys. So no more. Now we have 5. If it were only 2 categories, if we had rich and poor, then what test would you do? T-test, right? And if you did T-test, what would be the null hypothesis?
Now, the case in the poor is similar to the case in the rich.
Yes, but it's specifically the average.
The average.
Height for age.
Average.
So if it were 2 groups, rich and poor, you would say the average for the poor is equal to the average for the rich. Right? That was our 2 sample T-tests. So now we have 5. So all you have to do is say the average for the poorest is equal to the average of the second. Is equal to the average of the third, or the middle is equal to the average of, what is it, fourth and richest. So
Where you say the average of the case is similar in different on time.
sorry,
What if you say very poor, like the average of the case, the aggregate is similar in different on time.
yeah, average HAV is not even similar, it's the same.
It's the same.
Like not
It's equal in different, it's equal in different on time.
same for all
For overall,
wealth categories, wealth quintiles. Quintile just means the group. Quintile means 5. So quintile is 5 groups. So that's sometimes you see people, they'll just write, you know, mu is all equal, or and then the alternative, they'll just say, so the alternative to everything being equal is at least one is different. Maybe everybody is different. But the opposite of this, the alternative hypothesis is always the opposite. So the opposite of this means at least one is going to be different. Maybe 2 are different. Maybe everything is different. Maybe 3 are different. Maybe this one is high, that one's low. Like, can be anything, really. So that's going to be our null for the ANOVA. And then, okay. So then we will do an ANOVA. Do you want to say the ANOVA for tomorrow? What's that? You want to see the answer first?
no, I just want to repeat what's wrong.
What's that?
No, I just want to know now
Oh. Okay. Well, let's just look at the answer, but we'll go back again and let's just do the test, see the result, and then we'll go home and then we'll come back and maybe we refresh this again tomorrow because you have a chance to just kind of look. So let me, because yes. So this is the syntax. You do one way ANOVA. This is our Y, height for Z, height for age. This is the category. And then we have many conditions, right? We don't want HAZ to be too big. We want to exclude the 9/9s, and we want that wealth category, that zero, that weird zero category, we want to omit that one too. So it must be greater than 0. And then I put this comma, and I put this tabulate option. Okay, we did this. That's great. Here's the result. So the tabulate will give you this information, which is very nice. So I have my 5 categories. Here is the average HAZ. And this actually follows a really interesting pattern, right? The very poorest have a very negative HAZ on average. The next one, it's still quite negative, but it's less. It's a little bit better. And as you increase the wealth, the HAZ, it's increasing. It's still negative. So clearly, even the rich one, even the richest household still has some underweight, or sorry, has kind of stunting, probably has some stunting, because we expect if it's healthy, this average should be 0. So, yeah, but this is not bad. The rich one's not bad. This is pretty bad, right? On average, most of those kids are going to be stunted. So this is a very nice, again, this is not a randomized situation. Obviously, I can't give you money and make you wealthy and take away money and make you poor, right? Like, it's not randomized, it's purely observational. But what you see is kind of like, you can call it a dose response, right? The more money a family is having, the less negative, the more increasing height for HC is on average, right? So it's a pretty, for me, it's rather convincing that wealth is really having some positive effect on linear growth. But you have a lot of standard deviation here. There's a lot of variability. And so we do this F-test, ANOVA F-test, and here is our p-value. And that's very, 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 very small. So what do we conclude? What's that? P-value is basically, sorry, this one, F statistic. This number. So,
P-value is 0.0505.
Therefore, you do what?
That's enough to reject the hypothesis.
Okay, which means you reject so what do you conclude?
Yeah.
So what is the answer? What do you tell the community?
That the fit to be proved compared to it. Compared with that. That's right. The second video board that we check on of them is the lucky place.
Not different or different?
Difference.
They're different.
Difference.
Yeah.
It's significantly.
Yes. So at least one of these, right? This average HAZ is going to be different across the wealth categories. In what way is it different? We don't know yet. We're not looking at those numbers yet, but we have an idea of how it's working, right? Because we see that means. We're not going to go that far yet. Just this pure 1 p-value is just telling us these means are not all